And in some cases now, and this is in trials, do patients even need to get chemo after either surgery or radiation? Do patients who have had definitive or curative therapy have a recurrence or relapse of their cancer before the imaging detects it? And then patients who are on treatment, are they responding or not to that treatment? And like I said, this is very unique. Your genes in your body, in your tumor, are significantly different than the same patient with the same diagnosis in the door next door who has the same histology, but their DNA is completely different because all of our fingerprints are different. Your cancer is genetically different than everyone else's. So the idea is to make a test personalized off of your tumor or your patient's tumor. So what ends up happening is that we'll take a tissue sample that can either be from a biopsy specimen or from a surgery, and then we'll take a blood sample. And ultimately, those two things are brought to the lab where a customized test is built. And that customized test will end up figuring out the tumor's DNA fingerprint or its signature. And then we'll take a blood test and we'll see, do we find it in the blood test at that time? And then you could continue taking blood tests over time and saying, is it still there? Is it gone? Is it higher? Is it lower? And that allows you to be able to follow the tumor in a much more sensitive and specific way, even more so than the traditional tumor markers such as CEA, who sometimes aren't really giving us a clear indication of what's going on. Now, what you'll end up getting on your report is either a negative result or a positive result, so it's binary. A negative result means that they found absolutely none of that tumor's gene sequence in your bloodstream. And what that can mean is that the tumor has been cleared from the bloodstream, it stopped shedding into the bloodstream, all of the cancer's been removed from your body. There's various ways in which the team looks at that and says, what does it mean? If it's positive, it means that likely there's still some cancer cells left somewhere in the body that are excreting this tumor DNA into the bloodstream. And it may not even be visible on imaging, it may not even be while you're on treatment, and it may not even be at a time where you would expect it. And what it does is allows us to make quicker decisions in real time. And this is what a report will look like. So for instance, someone might have a positive test at diagnosis, and then what ends up happening is perhaps they get some chemotherapy and it goes lower, but it's still not zero. And then they get surgery and it goes to zero, and then they are on surveillance and it continues to be on zero. And it allows you to track it over time about what's going on with your cancer diagnosis. And it lets you know if you're responding to certain treatments, such as surgery, such as radiation, such as chemotherapy, immunotherapy. Now, there's a lead time. And I think that that's sometimes difficult for patients to understand is, you know, I got my blood test done, where's my results? And the first test only will take about 4 to 6 weeks to come back. Why? Well, they're sequencing the entire genome. It used to be that took about 10 years, and now we're at a point where we're doing that at about 3 to 4 weeks. And it will get quicker, and it will get shorter, but that's where we're at today. But after that test and that gene signature has been identified, what will end up happening is every subsequent blood draw is just looking at that gene signature for that patient. So it'll be 16 genes. And 16 genes you can do in a couple of days. So when you do that in a couple of days, what you'll be able to do is get quicker turnaround. So you'll be able to make these decisions in about a week or so about what's going on with the patient's blood test. So a recent study was published in Nature Communications, and it was called the Plagast study. And basically what they said is you know what we're going to do? We're going to look at everyone with locally advanced gastroesophageal gastric cancer, and let's just check their ctDNA at diagnosis, before they get chemo, after they get chemo, before surgery, after surgery. Let's just track it over time. Let's see what it means. Let's see how it differs from imaging recurrence. Let's see how we're able to show it against CEA. And let's try to figure out how we would best use this in a gastric or gastroesophageal population of patients. And you'll see that the neoadjuvant treatment and the surgery were part of this study. They were looking at how the blood samples would be evaluated at each of these events. And what you'll see is that there are traditional ways in which we look at recurrence, right? You'll end up having chemotherapy, you'll end up having surgery, you'll sit with your surgical oncologist or your oncologist, and they'll say, we found 2 lymph nodes. The cancer was signet ring, it was grade 2. It has these specific lymphovascular or invasive features. And what we found is that's the traditional way of which we determine prognosis or how risky a cancer is. And in the past, we used to use like lymph nodes, right? And if your lymph nodes were positive, you'd probably have about a 3.7 times chance of recurrence at that point. And we have other scoring methods that we use, but ultimately what ends up happening is that you have a DNA test built off of that tumor that is exquisitely sensitive and specific for it. If that's positive, you are going to expect there's still disease there and that your recurrence or your inability to clear is very much higher. And you'll see that if you're on neoadjuvant therapy, chemotherapy, immunotherapy, and you're still positive, you actually have about a 4.7 times chance of your cancer still being there. That's even better than lymph node status. If you've completed your neoadjuvant therapy and you did not yet clear your ctDNA, you have a 7.3% chance that your cancer is still there or recurrence. And then say, all right, fine, I got on chemo, it's still positive, but now I'm going to go to surgery. And after surgery, when that mass is out, I want to see that gone. And if it's not, you have a 14.5 times chance of it coming back. And this is more than you would even suspect from someone having a positive lymph node or 2 or 3. So the idea is that over time, being able to clear your circulating tumor DNA provides prognosis. It provides you an understanding of the treatments that I've been giving right. Have they worked for me? Have they been matched to my tumor? Have I done enough cycles? Should I try to do that one last cycle and see if I can get that down to 0? Because it seems to make a difference if you're capable of clearing at certain periods of time, and the earlier you clear, the better your outcome will be. What I'm going to do now is run through a couple cases that I've had in which we've used ctDNA in specific instances, just so you can get an idea about how the clinicians use it on a daily basis. So I currently have a 60-year-old female who was stage 2, HER2 negative. Immunotherapy markers were low, but claudin positive. And she had a signet ring gastric adenocarcinoma. What we ended up doing was she was at another institute, and she had her EGD, and they did random biopsies in the stomach, and they found that it was diffuse. She ended up having an exploratory laparoscopy that showed that there was no peritoneal disease. So we said, all right, at that time, the standard of care was FLOT, 5-fluorouracil, oxaliplatin, and Taxotere, and we do that perioperatively. So what you end up doing is you do your chemotherapy, you go to surgery, and then you restart your chemo. So it's kind of like chemotherapy, surgery, and then cleanup chemotherapy after. And what we were able to do was once she transferred over to UCSD from the community setting, after her gastrectomy at UCSD with Winta Metzen, our surgeon, we started tracking the ctDNA, right? Diffuse cancer is very difficult on a biopsy to get enough tissue to run one of these tests, but once you remove the stomach, you will have enough tissue to be able to make the test. And that's a caveat. You need to have enough tissue to be able to make this test. So ultimately, her ctDNA was negative in May, and it was negative in July, and it was negative in November and January. And she's recovering, and she's traveling, and her imaging's negative, and her CEA is 3.1, and she's feeling great. And then all of a sudden, right around August, we get a ctDNA, and it's positive. And at that time, she was actually in Europe, and she's like, oh, I got my ctDNA positivity. What does it mean? And I said, at this point, it means you're at high risk of recurrence. And what do I tell everybody? I said, this is a smoke alarm. When the smoke alarm goes off, you go look for a fire. If there's no fire, you turn the smoke alarm off. And you wait, and you see if it goes off again. If it goes off, at that point, we'll continue getting more imaging. But honestly, your imaging hasn't helped you. And in diffuse gastric cancer, it doesn't usually help very well because it's usually spreading. It's not bulking. Unfortunately, she landed from Europe and went right into the hospital with a bowel obstruction. And we did an exploratory laparoscopy, and she just had peritoneal disease, which is unfortunately very common with diffuse gastric cancer. So, of course, it's disappointing for her, disappointing for her family, and she said, well, what are we going to do next? And I said, well, you're Claudin positive. Zolbetuximab has been approved. We're going to put you on the GLOW, basically the GLOW study, Capox plus zolbetuximab. We gave her a cycle and then got her ctDNA, and it's 0 again. So what's that do for us? It lets us know, hey, that treatment's working. It lets her and her family know, hey, that treatment's working. And it allows her to kind of get back into her rhythm after that shock of metastatic recurrence. And it allows us to know very early on that she's responding. Because what else would we have done in this situation? We would have just said, your CEA hasn't helped us, your imaging hasn't helped us, let's just see if you get another bowel obstruction. But no, now we actually have a marker. We're able to track this. Here's a patient, 73, with gastroesophageal cancer. She was absolutely not a perioperative FLOT candidate, meaning she just would not be able to handle this chemotherapy regimen. So what we ended up doing with her is we said, well, we're just going to give you definitive chemoradiation, the cross regimen with carboplatin, paclitaxel, and radiation weekly. And after she was done, she had a confirmation on her EGD that she had a negative or a complete response. There was no evidence of disease there. And we had a lot of discussions about going to resection. Actually, she was a palliative care nurse and retired, and she said, I do not want to go to a resection. I have seen what happens with some of those patients. They're not able to eat and drink. Their digestive systems are off. It's just not something I want to do at 73. And we said, that's fine. What we'll do is we'll just use this as definitive therapy, and we'll just continue to track you. And you'll see, actually, she was ctDNA positive to begin with. We gave her the regimen, and then she went ctDNA negative. So we know that the test can pick up her tumor if it comes back. And she remains ctDNA negative to date. This is a very controversial area, but it's starting to become more and more popularized with things like rectal cancer as well, where if people have curative or definitive responses, we're actually not going to surgery with them. We're actually doing kind of a watch and wait approach, and that's what we're doing with this patient. We're doing EGDs and scans and ctDNA basically every 3 months, just making sure nothing is back. But it's what worked best for her. It's what worked best for her case, and it allows her to feel assured that, you know, if something were to come back, we either catch it on one of these modalities. Here's a patient here that we published last year, and this was a patient who had CAR T. CAR T are cells against specific markers. In this case, it was Claudin 18.2. And this patient went through everything you could possibly go through for gastric cancer. They went through chemotherapy, they went through HIPEC, they went through surgery. They went through various lines of immunotherapy, ultimately coming to a point where zolbetuximab yet wasn't approved and getting on the Claudin CAR T study. And basically after 2 infusions of CAR T, they had a radiologic complete response. The nodules within the abdomen had gone away and in the peritoneum. And with this patient here, what we really wanted to find out was not only does Claudin CAR T work, but also are we able to track responses to cell therapy with the ctDNA. And it was one of the first times that anyone had done this, and what we showed was every time that this patient had an increase in their ctDNA, meaning that the tumor was growing, and we gave them a dose of CAR T therapy, that ctDNA went down. And we were able to basically see in real time that the cell therapy was going in and attacking the cancer, even before that 4, 6, 8-week scan. And that's very, very important because it allows you to know with a very novel clinical trial that you're running that your patient's responding or not, and you're getting that in basically days from treatment. And it was really important for us to be able to show this because for most CAR T patients, we basically just say, well, let's see over the next 3 months, and then maybe we'll cycle you again. And in this patient, actually, we were able to prepare the next dose of CAR T because we saw those ctDNA start rising, and we knew that it's time to start getting those cells prepared and ready to go and bring that patient back in for another dose, and then they get another dose, ctDNA goes down, and we feel more confident again that that was the right choice. So in each of these scenarios, whether it's a gastric patient, gastroesophageal patient, whether it's chemotherapy, immunotherapy, cell therapy, or radiation therapy, What we're able to do is to show that circulating tumor DNA for that patient, very unique gene signature, is capable of giving us some information we didn't have before, some information that we can do things with, and information that we're able to help give the patient more information about what's going on. Something that always comes up to me is what happens if that ctDNA is going up and there's nothing on imaging? Aren't you just making the patient worried? And my argument is that, number one, we do it already. Everyone gets CEA all the time, and it rises, and imaging doesn't show anything. Number two is our patients want to know. They want to know what's coming. I think the biggest problem that we have is getting blindsided. So I think ultimately at the end of the day, if the ctDNA is rising, you can prepare yourself. You can come up with a plan. Your team can tell you, hey, listen, ctDNA is going up, nothing's on imaging, but this is what we would do. We would do plan A, plan B. You know what? Let's get some more tissue. Let's start some genomic sequencing. Let's start matching you for trials. Because if something does appear, let's be ready for it. The other thing about it is that some people will say, shouldn't you just treat someone whose ctDNA is rising? And my argument is no, you don't know where that recurrence is going to come. It could be an oligometastatic lesion in the liver, and what would you do? Radiate. And what did you end up doing? Saving somebody from chemotherapy. So there are various instances where the ctDNA tracking might be anxiety-ridden to the patient, but actually it's a way of empowering, I think, the patients and the clinicians. So in summary, this test, circulating tumor DNA, is a really good tool for us in the clinic to be able to detect in real time what's going on with our patients, what's going on with their cancer care, and how to personalize their treatment decisions. And we know that if you clear it early on, or eventually you clear it with different modalities, you'll actually be in a position where your prognosis is improved. And then we also know that it can be a smoke alarm. And if that smoke alarm goes off, we go looking for fires. If there's no fires, we turn it off. If there is a fire, we deal with it, and we're prepared to deal with that. All right, thanks so much. Yeah, we could take questions if anybody has any. Yes, ma'am.
Hi, thanks for the presentation. 2 questions for you. The first one is, in your experience with gastric cancers, are there certain types of cancers that just don't shed very well into the bloodstreams, or how often do you see ctDNA as 0, but there's still spread? That's one question. And the other question is, we know that biomarkers can change over time, and your recurrence, you might be different biomarkers than your original biopsy. How often would you recommend redoing the tissue part?
Yeah, great question. So the answer is yes, right? So if you have a large, bulky tumor in the gastric body, it's in a highly vascularized place, you expect to see DNA shedding. If you have something maybe within the peritoneum with low vascularity, you may not pick up the ctDNA even though there is tumor there because it's not yet hitting the bloodstream. So that's something that needs to be understood. Now, there's been publications on that, not only from our team, but from the team at MGH. And basically, the idea is that it still picks up better than imaging. And what we've been doing, actually, if your ctDNA is positive and you don't see anything on imaging, we're doing an X-lab to check that scenario. So that's actually a good point. To your other point, this is built off of the tumor, the primary tumor, the primary biopsy. So everything that happens from that point forward is of the same clonal origin. So you'll be able to pick up that kind of genetic signature no matter what happens with alterations with the tumor over time. So even though you've been treated with maybe something like a HER2 targeted agent, you would still expect to pick up that DNA over time with that patient. Yes, ma'am.
Well, she answered one of the questions.
Okay.
The other question was the signatera. Is a signatera a type of that next generation sequencing or that comprehensive genome profiling, or is it just ctDNA?
Yeah, so great question. So Natera has a full suite. Most of the genomic companies have a full suite of tests that they use. And each of the tests will have different names, but they're basically doing different things, looking at things from different perspectives. So the Signatera is the molecular residual disease test. There's also something called Altera, which is that comprehensive NGS panel, actionable panel, which is something like Tempus XT or Foundation or Caris. And then each of them are getting now towards having agnostic blood ctDNA, meaning you don't need the tumor tissue, you're just looking for methylated or specific DNA that's floating around the bloodstream. The positive of that is you don't need a tumor tissue for it. The negative is it's not very sensitive or specific for that patient, right? It's just kind of saying, well, if we pick something up, we pick something up. And that's the other caveat. You might get a blood test and it may not show anything, but that doesn't mean that the tumor doesn't have a genetic mutation. It's just not shedding it into the bloodstream. So a lot of times people are like, oh, I had my NGS in my blood, and I'll say, well, that's not good enough because it may not be shedding into the blood. You need to go get a tissue biopsy, which is kind of the empowerment of kind of the signatera test is that it's tumor informed. What is in that tumor is what you're going to pick up. So you'll see all these different sequencing companies. Their goal is to have the largest comprehensive end-to-end and vertical gene structure that you can do it, from germline testing to blood testing to tumor testing to molecular residual disease testing, RNA testing. So everyone's working on that now.
So my husband has stage 4 GEJ, adenocarcinoma, mets to a lymph node by his kidneys. So he did, essentially following the Matterhorn trial is what our oncologist did. So he had surgery in July, and then it was supposed to go back to the 4 rounds of FLOT. He's done 2. He had a signatera testing 4 weeks after surgery. It was negative. He just had another one 2 weeks ago. And it was negative again. I guess a question that I ask our oncologist, he doesn't believe in the signatera testing, so this is through an integrative nurse that we hired that is doing the signatera. Would it change your protocol, like as far as do you continue with the chemo, the strong chemo, do you lower it? Another one was that the oncologist was talking about doing targeted radiation to the original lymph node, but that had disappeared on the PET scan before surgery, and they weren't able to take that out during surgery because of its location. So I guess, do you change your plan once you're getting these results, or do you continue to move forward?
Yeah, great question, and definitely support what you and your family are going through. It's very difficult. Right now, there is no data, and that's what you can believe in something or not believe in something, but what's the data say? There's no data to say stop what you're doing from a clinical trial based off what's the ctDNA. No one has that data right now. So I would continue doing what you're doing. The caveat is that if your ctDNA is negative and you're running into toxicity issues with the therapy, you might feel more comfortable pulling back or reducing that because your ctDNA is negative. But again, this is kind of where the clinician has to decide what to do with it. Yeah, there is no current data that says if your ctDNA is negative after surgery and you're on durvalumab or FLOT, maintenance therapy, you should stop. No one has said that. It's just on case-by-case basis. Say a patient's not a candidate for FLOT after surgery, and your ctDNA is negative, okay? You're in a situation where now you have a marker. Or say you have an immune reaction to the immunotherapy durvalumab, and you can't get it anymore, and your ctDNA is negative, maybe you cut it back. So those are the scenarios where it's helpful to have that piece of information. But yeah, there's no clear evidence that says if your ctDNA is negative, stop treatment. All right, thanks everybody.
Okay, thank you, Dr. Bada. Before I introduce our next speaker, I want to share something personal. When my father was first diagnosed with stomach cancer, we were told he had 6 months to live. There was no multidisciplinary team, no coordinated care, and I was the one carrying scans into every appointment, listening to doctors debate different approaches in real time in front of us. Eventually, I followed the research and the innovation, which led us to Dr. Zev Wainberg. He looked at my dad's case and said something no one had said before. I think I can cure him. In 2014, Dr. Wainberg took an out-of-the-box approach that gave my father a real chance. And today, my dad is clinically cured. So it is with profound honor to welcome him today. Our next speaker is Dr. Zev Wainberg, speaking on clinical trial, innovation, and future directions in gastric cancer. Dr. Wainberg is a health scientist clinical professor of medicine and surgery and the Still Abbey and Marjorie Sanders Endowed Chair in Cancer Research at the David Griffin School of Medicine at UCLA. He serves as the co-director of the GI Oncology Program and director of the Early Phase Clinical Trial Research Program at UCLA Johnson Comprehensive Cancer Care. Dr. Wainberg's research focuses on GI cancers, including pancreatic, gastric, and colorectal, with an emphasis on early phase clinical trials and translational therapies. He is the co-chair of the SWOG Esophageal and Gastric Cancer Committee and a member of multiple national and international guidelines and review committees, including NCCN and ASCO. Please welcome Dr. Zev Wainberg.
Wow, I wish my family would be here for that introduction. Thanks, Aki, and you know, it's really I'm really happy to be here. I will say in advance, hearing Aki's story is really inspirational. I remember when her father came to see me all those years ago, and we were struggling with what to do. And you know, all you can say is sometimes things work out, and you're happy about it. So. And what she's built here is really remarkable over the last 10, 15 years. So it's great to see everybody. I will start by saying I didn't really prepare any slides because I find talking with slides for patients sometimes and patient advocates is challenging because, you know, it's very complex and there's a lot of clinical trial issues that come up, some of which is proprietary, others of which is just Kaplan-Meier curves and stuff like that nobody needs to see. But I wanted to spend a few minutes talking about just clinical trials and then open it up for questions. So one of the hallmarks of research is clinical research, and by that I mean clinical trials, drug development. This is a big part of what we do. I think that you know, there's certain things that have been very, very influential in gastric cancer over the last 20 years, and I'll just list them in order of what I think is important. One is the recognition that the cancers, gastric cancer is really a global disease, and by that I mean it is a disease that is very, very common in Southeast Asia, and there, in those countries of Southeast Asia, Korea, Japan, China, we are, you know, we learn from them a lot. We learn from them both surgical technique, we learn from them data sets that are valuable on retrospective biomarker reviews or even prospective biomarker reviews. And then we learn from them fundamentally on how to make studies applicable to an entire global population. So for example, you know, when you think about some of the most successful clinical research trials in gastric cancer, it's been that you have a group of patients from Asia, a group of patients from Europe, a group of patients from North America. And you don't necessarily see that in a lot of cancers. In a lot of cancers, sometimes it's driven by a North American Western patient population. Here we have a lot to learn from you know, how they approach it in Southeast Asia. So for example, if you've ever been to Japan, to one of these hospitals, where I've been a few times to visit some of my colleagues, you see how they screen every patient in that country for stomach cancer. And it's like a very rapid screening program that is done in, and it's not just Japan, Korea, even some parts of China do this, and they have, every patient gets screening endoscopy, every patient gets a very simple, and they have it almost like a, they have it worked out so effectively that they can screen thousands of people in a very efficient manner. Now, the reason they do that is because it's obviously the incidence of the cancer is so much higher in those countries. But we certainly, you know, here, even in this country, we probably aren't doing a good enough job screening high-risk people. And so if you think about high-risk patients and families, we could probably do better at screening those people, recognizing that screening is important. So we've learned a lot about screening from that side of the world. And then we've learned about how to enroll patients on clinical trials, because I think when we think about our infrastructure for clinical trials, it's not as good as it should be. We struggle with, emphasizing the importance. We struggle sometimes with explaining why it's important. We struggle with offering a counterbalance to probably some negative perception of what clinical trials are all about. We struggle overall with the concept and how to improve outcomes with these clinical trials. And then the third thing that I think is important is that, biomarker discovery, which is a big thing that I've been interested in for a long time, is something that we have to look at as a global thing also, because we have a disease here, gastroesophageal cancer, which is probably the most heterogeneous disease in some respects of any cancers. If you really think about gastric cancer and then you include esophageal cancer, which is, let's talk about gastroesophageal junction tumor, we're probably talking biologically about one of the most heterogeneous cancers. What I mean by that is that the diversity within that organ of what cancer is and what it represents is unique. You don't have a circumstance, for example, where even thinking within the GI tract of pancreatic cancer or colon cancer, which is that different depending on where a patient is in the world, depending on what their epidemiology is, depending on what their risk factor is. Yet in this cancer, if you look at just the organ that is involved, the GE junction and the distal part of the stomach, the whole thing is different. The risk factors, whether it's H. pylori associated cancers, or whether it's gastroesophageal reflux on the other side, whether it's talking about diffuse versus intestinal, whether it's talking about Asian versus non-Asian. The entirety of the cancer is really this very, very different thing, depending on all of those epidemiological and geographical risk factors. And they don't encounter that in breast cancer, colon cancer, pancreas cancer. It's not that there's not differences in outcomes depending on where you live. That has to do a lot with socioeconomic status also. But in terms of the biology of the disease, it's different. So what that's meant is that, as we've learned about important biomarkers in HER2, as we've learned about important biomarkers, whether it's MSI high, Claudin, or whatever it is, we've had to reckon with this kind of weird situation that is different and depending on where in the stomach your tumor starts, or depending on where in the GE junction your tumor starts, and sort of that's been an uphill climb because we usually that's not the case. Usually you have the benefit of saying, okay, disease like pancreas cancer, 90% of patients have this mutation called KRAS, and that's it. It doesn't matter where in the pancreas it starts. Colorectal cancer, 50% of patients have KRAS mutation. It doesn't matter which side of the colon, it's still there. Here in HER2, we're dealing with very different parts of the organ, different incidents of the biomarker. So some of these things has been a struggle, I think, in intellectual struggle, but also sort of a recognition that what goes on in our country, which is 25,000 or whatever it is cases a year, is very different than what goes on in China, Korea, and Japan, where it's 10 times that in terms of the incidence. So that's one of our uniquenesses, I would say, unique qualities of gastric cancer in this country. But being involved with clinical trials over the last 15 years in this disease has been really exciting. I think we've had, in some ways, great success. I look back and I see outcomes that I probably never would have predicted 15 years ago. I think we approach the disease differently, both from the time of diagnosis and even if it ends up in a late stage situation. I think we've kind of all come around, everybody who treats this has come around to the notion this is a multidisciplinary team that cares for these patients. All of that didn't really exist in any sort of comprehensive way about 15 years ago. It was really a lot of, surgery straight away, then maybe some chemo or radiation, and sort of, I think progress has been very significant. Sometimes not as fast as we would like, albeit, but significant over 15-year periods, as long at least as I've been doing it. So all thanks for your attention. Happy to take any questions regarding clinical trials, whether it's existing trials or upcoming trials, or any thoughts or comments that anybody has. Yep.
So my stomach cancer started, I had gastric bypass surgery in '94, one of the first ones, and they left the residual stomach in, and they found a 3.3 centimeter tumor in that stomach. Ended up removing it. I went through chemo and radiation, and I had a recurrence they found 3 nodules in my right lung. Went in there, and it's the adenocarcinoma. When he went in there, there was lesions on my diaphragm, and more lesions in my lung, and also in my pleura. So I don't have where it's in my peritoneal sac, but in my pleura sac. Are there any trials or anything coming up where you're trying to do something like that, so I'm not this unique unicorn?
Well, it's sometimes good to be a unicorn, right? So I don't think so. I think pleural-based disease is very rare, and as you pointed out, so it's hard to imagine there's a direct clinical trial to that. Some of the pleural-based techniques, though, surgical and otherwise, that are borrowed from the mesothelioma specialists are being employed in some capacity, and that kind of unique subset of stomach cancer. But I think you bring up an interesting topic also, because like the patients with prior sleeve gastrectomy for obesity, right? We know sort of there's a increased risk there. It's been anecdotal, and it's hard to put that into data sets. There's a sense that people have had prior gastrectomies for, let's say, obesity purposes, do have a higher risk down the road of getting stomach cancer in the remnant stomach. It's probably to do with manipulations of the, whether it's the risk of reflux that is now there in a different part of the stomach. But nobody really has put that in paper, but it's definitely been out there in the literature, which will be interesting because, of course, as everybody knows, that whole field of gastrectomies for obesity is shrinking every year now with our GLP-1 agonists out there. So we're approaching a situation where in the next 5 years, probably, we won't be doing too much in the way of laparoscopic bands or sleeve gastrectomies for obesity prevention the way we used to. GLP-1 agonists are taking over that space, and also GLP-1 agonists have the added advantage, if you believe some of the data, of having some cancer risk protection for certain cancers as well. So, I think the whole, that your example of course, of your case is quite demonstrative of a emerging series of very interesting questions.
Yes, I had my gastric bypass in 1994, so it was one of the first ones. And so now what my oncologist has me on is Folfox and that ziziblab, whichever, I can't say that medication.
Something MAB?
Yeah, there you go.
Okay.
And it's every 2 weeks, but it's like every 2 weeks forever, so.
Yeah, well, you look great, so you're doing something right.
Yep, thank you.
I was just going to ask you, can you just expound on that GLP-1, how that is a cancer protection? I just got a
So,
whisper
I
of
mean,
it.
it's coming out pretty early, but, probably the one where people think it'll help reduce cancer risk is in pancreatic cancer. Just, I don't know if it's not going to be gastric cancer specific, but the whole insulin axis that is affected by these drugs may portend a lower risk for things like pancreas inflammation, pancreatitis, things that sort of can chronically lead to pancreatic cancer. There's actually a lot of early data sets that are looking at this. They're starting to collect these, because these drugs have, even though we've been hearing about them for the last 2 or 3 years, they've been in study for a little more than that. So the patients that are enrolled on those studies, GLP-1 agonists, have been, you follow them for years and you see everything that happens beyond the main goal of the drugs, which is to reduce weight. You're also looking at reduction of course, diabetes, which is how they're got approved, but also cancer. And so that takes longer because you have to have enough patients in each arm to study, but the early indications are that there are probably some cancers that will be reduced in an otherwise vulnerable patient population, that being obese patients. I'm not advocating for everybody to use them to prevent cancer, by the way, just so we're clear. I think it's in the people who get them for whatever reason, whether it's reduction of diabetes risk or obesity, there may be improvements in the risk of cancer, which is why, for example, the sleeve gastrectomies, laparoscopic banding surgeries might not be in anybody's. It won't be as common moving forward, especially if the oral pills come out, which are going to be much easier to take than weekly injection.
Hi, Dr. Wainberg.
Makes me want to take it now that I'm thinking about it, yeah.
Got 2 questions for you over here in the corner. So 2 questions. One is, what have you seen? What are your thoughts on the role of AI in terms of advancing clinical trials, in terms of the speed, the efficacy, and all that? Second question is, what are you seeing are the advancements in accessibility, just from a patient perspective? The idea that I'm going on this trial to get an infusion. Why do I have to be in that state to get an infusion if it can be given in my current state, right?
Yeah, really good question, challenging question. Clinical trial logistics and how to improve on that. Huge problem. I really agree with you. I mean, so for example, the biggest frustration I think that patients have, that I also have, is that you can't figure out, there's no way for a patient to figure out whether there's a slot open for them, whether the study is in the right phase 1 or 2, without physically showing up and talking to the doctor or coordinator, because you go on clinicaltrials.gov, which says, okay, it's recruiting at Dr. Iqbal's site over there at USC. But that input that was put in last year or whatever time, it doesn't mean it's actually still recruiting at USC or UCLA or City of Hope or wherever. And so if you're a patient, how are you supposed to figure out if it's actually recruiting? For all you know, the study's closed, or the study's still open, but it's not relevant for you anymore. And so I get all sorts of emails all the time, and my coordinators do, and then I sometimes we all struggle with this because there is no way for anybody, it can't be updated in real time. Because what's happening is there's, let's say, a 500-patient study that's enrolling globally, and it changes day to day, literally, because there's sites that are enroll patients in, Europe, Asia, all over the world, and then the number of eligible slots goes down by definition. So it is one of the real challenges and struggles that we face is there's no simple way for any patient or their advocate or their family when they're doing their research about what they want to do at this point. to be able to figure it out. And it's a huge frustration for the doctors too, I find, because the last thing we want is like a patient coming in, you know, and saying, hey, I'm here to talk about this clinical trial that you're doing, and we don't have a slot because we closed that 2 weeks ago or a month ago, and there was no way for the patient to know. It's, you know, I share that frustration very, very much. I don't have a great solution. I hope AI could solve that. That would be something exactly where AI, it requires the companies who are sponsoring the clinical trials to input that data, right? So it requires them to update these, whatever database we're using, to see where the clinical trial is in its state. So I think you're absolutely right. AI would be, okay, that's somewhere it could really help. I think your second question about AI was related to, like, why should you get infusions, right? So we have gotten a little better in this, right? It used to be that you couldn't get infusions anywhere, and now, for example, like one of the things that we've done in our institution is set up all these satellite sites all around Southern California, so that, for example, if a patient is just getting the same thing that they would otherwise get in Long Beach or in Santa Barbara or in, you know, Tuscadero, that they can get their standard treatment locally without having to come down. That where it gets tricky is if there's an investigational drug where the doctors in those satellite sites don't have experience with, and so then you sort of have to juggle that. So that's a huge, it is a huge issue. I mean, AI does have its uses, I think, for that kind of thing. It also has its uses for pathologists and for, you know, ways to come up with some other things that we're working on pathologically. All right, thank you very much for your attention.
Thank you, Dr. Wainberg. So yesterday I had the pleasure of introducing 4 incredible female doctors, Dr. Wu, Dr. Castillo, Dr. Sinthal, and Dr. Sharaga, who each spoke on their research. Today, all 4 of them are lucky to be joined on stage by even more incredible doctors. The first doctor I'm going to introduce is Dr. Wan Gong, a medical oncologist with Cedars-Sinai. Dr. Gong is an associate professor, Department of Medicine and medical director of colorectal cancer, Division of Medical Oncology at Cedars-Sinai Medical Center. His primary clinical interests are gastrointestinal and hepatobiliary cancers with a multidisciplinary focus of care with colleagues from surgery, gastroenterology, radiation, oncology, radiology, and pathology. Dr. Gong is focused on translational and clinical research with interest in early therapeutic trials, which include immunotherapy, targeted therapies, biologics, and other synthetic therapies, and biomarker development to improve patient outcomes in GI cancers. Thank you, doctor. Our next doctor is Mark Garrigus, surgical oncologist with UCLA. Dr. Garrigus is an associate professor of surgery at the David Geffen School of Medicine at UCLA, chief of GI surgical oncology, and director of robotic surgery. His interests include robotic and minimally invasive approaches to surgical oncology, and more specifically on gastric disease in clinical practice. He is committed to improvement of cancer care through innovative technology advancements, as well as groundbreaking research. His research focuses on developing novel small molecule targeting gastric cancer for radioligand therapy, and is part of the multidisciplinary group that collaborates on a variety of projects centered around developing new therapies for cancer patients. Next is Dr. Miguel Birch, surgical oncologist from Cedars-Sinai. Miguel Birch is a professor of surgery, division director of general surgery, and chief of minimally invasive gastrointestinal surgery at Cedars-Sinai Medical Center. His work focuses on benign and malignant diseases of the stomach and upper GI tract, including gastric cancers and complex revision, foregut surgery. Dr. Birch has led and co-authored clinical and translational studies integrating surgical intervention, fluorescence-guided imaging, and data science to advance cancer care. Next, we have Dr. Seema Iqbal, medicine oncologist with USC. Dr. Iqbal is an associate professor of clinical medicine in the Division of Medical Oncology at the Keck School of Medicine, Norris Comprehensive Cancer Center, where she serves as the section chief of gastrointestinal oncology. You know, once you're up here, your mouth starts to get dry. You know, GI. She is medicine director of ambulatory and inpatient services at the Norris Cancer Hospital. Dr. Iqbal's research focuses on GI oncology. Thank you for that. See how much easier that is? And clinical trials with novel drug combinations and identifications of potential markers of outcome. We also welcome back Dr. Wainberg. So thank you, Dr. Wainberg. Finally, to round out the panel, is going to be myself. A quick recap, my name is Jason. I was diagnosed in 2018. Stage 2 was on a clinical trial that included flat chemotherapy with immunotherapy. Dr. Wu is my surgeon. I've been cancer-free since 2019, so thank you. Thank you, Dr. Wu. Woo-hoo! And at the very end, we have Frank. Please welcome Frank. Thank you, Frank. Frank Landon's cancer journey actually began with a series of misdiagnoses. So originally, Frank was diagnosed with testicular cancer, but after 2 cycles of chemotherapy and review of his pathology, it was actually shown that he was a metastasis from gastric cancer. So Frank is a stage 4 gastric cancer patient, yeah, I guess this is our panel. So.
Awesome. Thanks, Jason. So this afternoon, you have an entire panel of experts and patients, and this is your time, okay, for you to talk and ask all the questions that you want, but we'll do it sort of topic specific, and you can pick anyone you want, all of them if you like, but we're going to talk first about the importance of multidisciplinary approaches to advance gastric cancer, and most of you, I know, have advanced gastric cancer family members. And so do you have, if there is somebody that has a question or wants to share their story or some of the challenges about getting multidisciplinary care, what's important to have, who you need to see or meet when you're diagnosed with stomach cancer. Anybody want to raise their hand and ask a question? Sure. I think we need a mic.
Thank you. I was talking to Dr. Wu yesterday, or rather last night, so I'll make a very, very short. As she was looking through my things, again, I started with the heartburn, the this, the that, and I thought that I had gastric cancer. I went through 4 months of chemo, except that it spread everywhere. I don't know if you guys know Dr. Bobby Egbalier. He works in Southern California. So my surgery, I ended up having an esophagectomy, a total gastrectomy, partial pancreatectomy, removal of the outer margins of the spleen, gallbladder, lesser and greater omentum, and 7 wedges of my liver were removed. The coronal, hepatic, splenic vein all had to be redone, and I've got nothing but staples and clips. In 2017, I had TAH-BSO for cancer as well. My question is I was told I had gastric cancer and it had metastasized. Did I mention my esophagectomy, a Roux-en-Y, and esophagojejunostomy reset? So having all that done, my doctor initially did circulogene testing, the gene, and what he told me is that I just have NTRK gene mutated adenocarcinoma, and my PD-L1 pathways are positive. This was back in 2021. I've had the same treatment of Keytruda every 21 days, and that's it. I've had no further testing, no further markers, no further anything, because he figures my PET scans have been negative for the past for the past 2 years. So he's like, okay, your treatment's gonna be the same. There's nothing we need to do. However, I'm listening to you saying that it is gonna come back because the pathology report actually showed the cancer was extrinsic from my stomach, so I don't have stomach cancer. So my question to you is, he's a fabulous surgeon, but should I go elsewhere? Because I just figured that my ball is just on the floor since it's not doing anything. Does this make sense to you? Because I would like to get sequencing.
Yeah, so I think the question would be like, what is your next step? And you can ask the expert panel. This maybe, can we get a surgeon and a medical oncologist to jump in? And at this point, what is the next step that she should do? Who should she see, and what needs to happen?
I'm in Los Angeles, by the way. So, and are you taking patients in? Jump in the chair.
I think it's on. Yes. I think your question is more of what should be the right method of surveillance and the right approach to manage your whole body at this point. So the surgical part, I mean, there's so much to dive into the surgery that you had, and also the subsequent surgery that you had. That is probably not the question at this point. So the question is, how do you manage, and what is the best way to surveil a patient like you who has or had cancer that has gone outside of the organ and got into the peritoneal cavity, right? And that's one thing that Dr. Bada also brought up, is in some instances, especially what we call it as peritoneal carcinomatosis, how sensitive is circulating tumor DNA testing? Will it pick up the early recurrences in the peritoneum? And his comment was spot on in terms of saying, yes, at this point there is a big gap, and the sensitivity of the testing that we have is not 100% to identify recurrences, particularly in the peritoneal cavity, but it is probably in conjunction with other tests that we have, is still worth getting, and if it is positive, then there is something that you can do about it. But keeping a healthy suspicion that negative doesn't mean no disease. Right? So that is how we would approach when we are thinking about ctDNA testing in patients with peritoneal disease at this point. So no single test is 100%. It is corroboration, clinical corroboration with all the testing and diagnostic modalities that you have is how a clinician can advise what the next steps are. In terms of your treatment, I'm going to defer to the medical oncology experts. Literally, you have the world experts here between Dr. Iqbal and Dr. Wainberg. So I'm going to defer to one of them to address that question.
So first of all, that's great that you're gone through all this, and made it through and you look fantastic. So congratulations. A lot of work, a lot of surgeries, and great outcomes. So, I mean, I think when I don't think we should say after hearing your story that we know what's going to happen. That's kind of not necessarily the way I look at it, at least. I think you've had a fantastic outcome to date by our standards. Obviously, there is always going to be concern about a recurrence. Doesn't mean it will happen. And so I don't know if we can, you mentioned that everyone tells you it's going to come back. I don't know that. That's not really the way we think about it. It's more that, there's this lurking concern. Doesn't mean it will happen. And that's why, changing treatments is not always as simple as it sounds, because you end up having, we don't know what would happen if we change treatment. And someone who's done so well on a single agent pembrolizumab as you've been on, it seems, just, I don't know, I'm not going to go out on a limb and say, it seems you're sensitive to that particular agent, so, and it's done well by you. So I would probably not change it necessarily, and not to suggest that I'm making a medical recommendation right now, because I can't do that. But in terms of, it certainly sounds like the treatment's been effective. So I'm leery to change people's treatments if things are working. And I think the thing with ctDNA that we have to be careful about, right, and Dr. Bada said this, and he's a specialist in this, is we're not yet at the point where we absolutely should be changing treatment based on an individual ctDNA value. ctDNA is prognostic. It tells us that the cancer could come back and very well likely will come back statistically. It doesn't inform the oncologist that says, oh gosh, that ctDNA is bumped up from 2.2 to 2.7, now we should change the treatment. Because ctDNA in some ways is a much more sophisticated molecular-based tumor marker. And we never did that for CEA or CA, and we shouldn't be business, in my opinion, of changing people's treatments yet. And I say yet because the future may change that, on the basis of just what a ctDNA individual value is. So that's my thoughts.
So I have a question about, so how many patients are currently under active treatment? For any therapy, immunotherapy, chemotherapy, trials, okay. How many of you are followed by your medical, how many of you had surgery and then are being under treatment still? Okay. How many of you are followed by both your surgeon and your medical oncologist? All right. So one of the questions I had to the panel is, for patients who had surgery, and it's sort of obvious that surgeons follow our patients for post-operative things, but what about patients who didn't have surgery? Like, when is the time, I'll ask to the medical oncologist, especially for stage 4 patients, when, if ever, do you refer a patient for surgical evaluation?
So I can think of a couple scenarios in stage 4 patients that we've needed our surgeons' help. We always firstly prioritize a multidisciplinary approach. So most cases we try to discuss at our tumor board to begin with. So that's where the surgeons and pathologists, radiologists, and medical oncologists are there. A couple of cases are if for example, there's some difficulty with nutrition. That's a very important aspect of management of gastric cancer. We've often asked our surgeons to weigh in if sometimes more interventional nutritional approaches are there. They've often helped us with assessment of if treatments are working too. Specifically, sometimes if the disease is not accessible on conventional scans, for example, those with peritoneal disease, we've often asked our surgeons to assess even with diagnostic laparoscopies in that regard. Then there are novel clinical trials that involve our surgeons involving intraperitoneal therapies, they definitely are involved in that aspect. And I may be missing a host of other ways that we've collaborated with our surgeons routinely.
Yeah.
We've even had some kind surgeons help us get a port in because we just can't get a port in time for our chemotherapy patients through our procedural center. I have comfort that Dr. Birch is a call away and he can just place a chest port for us overnight in the next 24, 48 hours, for example. And I'm not doing a good service, but we appreciate them so much, so I'm probably missing a lot of other ways we collaborated.
We'd love to hear from the rest of the centers, medical oncologists and surgeons, especially medical oncologists, if there's anything that was missed, or it's just in terms of getting multidisciplinary care and when and how surgeons and medical oncologists sort of talk to each other, and when the patients are referred. I think, thank you, Dr. Gong, I think those are really important times.
Yeah, so in the same way, I think at most academic medical centers, you're having cases presented to a multidisciplinary team, and that's a very important part of assessing each of our patients. We want each of the team members to give input on these cases, but we don't want to do interventions that are going to delay appropriate care for our patients. So it doesn't mean that every patient needs to see a surgeon before they start chemotherapy if they're actually presenting with advanced disease. But you've gotten some input in these multi-D settings that if there aren't complications that need to be addressed by a surgeon and they have advanced disease where the appropriate next step is starting chemotherapy, you've had input, but we don't need to take the time to have patients go to various doctors that won't be offering them immediate intervention. So in the advanced setting, as you've already heard, establishing nutrition, or if patients are having complications from the cancer itself, like obstruction, as you know, these tumors tend to bleed. Some of these settings can warrant that our surgeons take care of the acute issue, so then we can get on to getting chemotherapy, or immunotherapy, or whatever antibody is identified as appropriate into the patients in a safe way, and that it won't interrupt care as we're going through treatment.
Anyone else want to weigh in?
I have
Sure.
another thought too. We've often asked Dr. Birch to get us more tissue when we need some molecular profiling as well, whether for standard of care or trials.
I mean, I think I successfully turned it off. I operate better than I work a microphone. I hope. Thanks. I think one of the issues around collaborating with our medical oncologists often is tissue, and I think that it's underestimated, maybe undervalued, how important tissue is. You don't know what you have until you get some tissue. When I was in medical school, the pathologists used to say, "It's not cancer until I declare it cancer," which is still the truth. So that is an important part of our job with our medical oncology colleagues. The diagnostic laparoscopy for certain patients who have advanced disease, there is no other way to get tissue at times, and I think that is one of the ways that we've collaborated a lot together in terms of getting additional tissue after therapy. If people stop responding to therapies that Dr. Gong offers, sometimes I get asked to go give additional tissue that way, and it's something that sometimes is scary to patients if they haven't heard about it before, but really it can be managed really well, safely for patients to go through. And so that's one thing I wanted to mention because it's a patient forum, and so it's not unusual for us to do those kind of things.
I think there was a question from the audience.
Yes, yeah. My name is Crystal. My husband is a stage 4 gastric cancer patient. Just wanted to share a bit more of our experience and then have a question for the whole panel. When you think about multidisciplinary approach, honestly, I feel like a term that came to mind is multidisciplinary hope. I feel like every one of you that is here right now is offering multidisciplinary hope for patients. So thank you for being here, first off. we're from Seattle, and his treatment originally started stage 3, moved to stage 4 from Fred Hutch, and the surgeon who did the gastrectomy after his first recurrence very much had the mentality, or at least gave off the vibe, that, you're stage 4, surgery's not an option, I'm sorry, try to move on. And so I took that as not our answer. We went on to find Dr. Wu, who, provided way more hope for us, for my husband, attempted surgery. Unfortunately, that didn't turn out as we wanted. So now he's on third line. But my approach as caregiver has always been, my husband's job is to recover. His job is to rest. His job is to hang on to hope. And we have a team here to help him do everything else he needs done. And my heart goes out to patients who have to do that themselves. And I guess my question for you is, from your perspective, when you think about patient-centered care, giving patients the power to decide, but at the same time, we have I learned all this through the process, right? You have questions for the oncologist. You have to defer to the surgical oncologist for this question, refer to radiation for this question, refer to nutrition for this question. And the patient doesn't necessarily know that, but yet you're trying to give the patient power to make those decisions. What would you, if you had a magic ball or magic something, what would you think is the right next advancement in terms of offering the patient more power to make those decisions, knowing that you can only do so much, that you need a team of multidisciplinary care to give hope that they're going to beat this cancer?
Do you want to go ahead and
I think I can
answer.
start, but we have a lot of experts, today. I think they will give you a lot of input. And first, I want to thank you for supporting your husband, because you come to our center, and then we were able to, give some opinion to try to help your husband. And because of you, your husband is fighting with the cancer, and many of our patients don't have that support. So speaking of the patient-centered, I think sometimes we talk about the medical literacy, because when patients are fully informed about the options, sometimes I make example, we're working in the restaurant, we give our customers menu A, B, C, D, and then you tell them what the options are, and also what's the pros and the cons, and what's the risk, what's the benefit. Once the patient got all the information, I think you will make your decision. Sometimes we talk about shared decision, but it's very hard to do a shared decision because you don't know how much you understand about your condition, right? So, but talking about the multidisciplinary discussion is also very important. And then so we talk about the patient's case, we can tell patients oh, your case has been discussed at the tumor board, this is a radiologist input, this is the pathologist input, this is a surgical evaluation, and also medical, and what we can do, and then this is the challenges, and then also what the risk. And patient get all the information, they have to make a decision because that's your body, and also you have the capacity, capacity to make a decision.
So Crystal, I thank you, Dr. Castillo. So I struggle with this a lot because some of us, even though we're surgeons, we do see lots of patients with stage 4 peritoneal carcinomatosis with opening of trials and things, or consideration of conversion gastrectomy and all of this. And I struggle with this a lot because patients need a champion, the medical oncologist, the surgeon, the radiation oncologist, that's going to be the champion that at the end you come to discuss and make decisions. And I struggle with this because as surgeons, sometimes we have to let go. We can't be the person that helps you make the ultimate decision for whether the clinical trial, the stage 4, the chemotherapy, the immunotherapy. We can help guide you and be like a springboard, but we don't prescribe those drugs. But we may know, as experts in gastric cancer compared to some others in the community that may treat gastric cancer only once in a while. So I think that's a really, really great question that you raised, and I would ask that all of you find your champion in your medical team, whether it's a medical oncologist or a surgeon. Maybe the ultimate decision in treatment is not surgery or medical oncology. Maybe it's radiation, oncologist, whoever you trust the most, and continue your conversation with those that person along with others. We try really hard when within the institution. I think it's somewhat easy, but when patients go away and they're in different states and where we don't have medical licenses, those are very difficult. So if anyone has any suggestions and maybe someone has had it work really well for them, do they want to share how their multidisciplinary team works? Sure.
Hi, my name is Ruben. I was diagnosed April 2021 with stage 4 stomach cancer, spread to my liver, spread to my lymph nodes. Surgery was not an option. Went through 30 rounds of chemo, been through 105 immunotherapies. I still continue on every other week. My journey has been great. I have no issues. I'm here. Like I said, I'm hearing about stomach cancers and people surgeries being removed. And, you know, I just like, man, everyone I talk to, their stomach has been removed, and there's very few in here that still have their stomachs, you know, and my journey has been great. I go to Kaiser out of Riverside, and yeah, I'm just amazed at, you know, how everyone's stomach has been removed, but, you know, so everyone's different, I know that. And I just continue on my journey, you know, and with good health, good spirits. And, you know, I thank you all for being here, you know, and listening. And I've learned a lot. This is my first time ever coming to one of these. And I'm so thankful to be here and everybody here has been, you know, been great to me, hearing a lot of great stories, you know. So, yeah, I'm just here to say that, you know, God is good.
Thank you for sharing. So I have another question does anyone want to share this? I have a question about, okay, go ahead.
I wanted to follow up. I'm Ruben's wife.
Oh,
so
sure.
The tumor was found in the cardia, and his oncologist has indicated that there was no surgery option. And so what we're doing now is immunotherapy, and my understanding is for the rest of his life. And so I guess our question is, are there any questions that we should be asking? Or is it, it's not broke, so don't fix it type of thing, and just continue on with the immunotherapy?
That's a really tough question to answer without knowing anything other than the 2 seconds of information. So, but I think there is some, without delaying care, obviously, some role in getting a second opinion, whether that second opinion is from another medical oncologist or from a surgical oncologist, just to evaluate your options when everyone's just saying it's just one option and you have questions. So you yourselves are wondering, what is the next step?
Right.
Right? And the answer you're getting, it may be the right answer, but it's not the one you like. Right? So you want another answer, but maybe the next but without asking someone else, you're just going to keep getting the same answer. Correct? So I would say that if you have these questions that are unanswered or you're not satisfied with the rationale why this is so, it's not just, we recommend this. We often tell you the reasons. And there are alternative options for some of these choices at certain stages in your treatment, especially in the beginning. So those alternative options should be offered and discussed with you. And if you're seeking additional options, they may or may not exist. But if they do, maybe getting a second opinion, we're talking about the importance of getting a second opinion, especially from a center that sees a lot of patients like yourself, I think would be highly, highly valuable, even if just to keep, put your mind at ease and give yourself some comfort that we did everything that we could. And we left no stone unturned.
Okay. Thank you.
Okay. Yes. There's a person next to you. Go ahead.
Hi, my name is June Park, and I'm a caregiver for my husband. And I just wanted to share our story because my husband was diagnosed last March 2024, and we didn't like have symptoms. It was very traumatic experience because he was fine, and one night he felt pain in his back, and I took him to ER, and he did a CT scan, and there was a big mass on his pancreas. So we thought it was a pancreatic cancer, and then found out it was a stomach cancer that spread to liver, lungs, and even spine. So at the time, he was given like 1-2 months, maximum 6 months. So it was a big trauma. And I am not a medical person at all, and I have an art degree, so I don't know all the terms that you guys know, so it was kind of scary to ask questions. So he was in chemo, because surgery was not an option. So he was getting chemo, and it's been very good. So in the beginning, he couldn't eat, and all this testing was done like within a week, so he was in, he couldn't eat anything because of all the testing, and so he lost so much weight, and he couldn't eat, and so doctor told me that just give him as much as he can tolerate. So I've been like forcing him, and I really hard to feed him, but now he's like almost back to his weight. So I have a tendency to just overfeed him. So I don't know if it's good to just keep a healthy weight or just be a little heavier than that. And then another one is he can exercise. So how much I have to push him to exercise, or do a little over, or just moderate?
So that's a thank you so much for sharing. And actually, I actually have that question. Should our patients who have lost initially a lot of weight and have an amazing response and get their stomach space back, I don't know about the function, but the space back after response to chemo, immunotherapy, targeted therapy, what is a good weight? I mean, I think, Sam, you look pretty good there. Yeah. Maybe BMI of like 24? 26, whoa. Okay, so I wonder what that good weight is. You don't want to be super obese because it's not good for your immune function and health, but does anyone want to weigh in on what an ideal weight would be for a patient undergoing chemo who is able to eat and gain some of that back?
So there's not a lot of data studying on exactly what's a perfect BMI or exercise regimen. Always more kind of, in terms of exercise, it's about lean muscle mass. I don't think there's a number for it, but you want to build muscle mass. So when you gain weight, you don't want to just have fat. You want to exercise, so it's more protein mass or muscle mass. Weight-wise, BMI, obviously you don't want to be underweight. There has been, not particularly to gastric cancer, there are some studies showing that a little bit overweight is protective for quality of surgery outcome, all surgeries. However, I don't think that's a good idea for gastric cancer in particular, because you don't want to be overweight as well. So I think, what range, because for Asian people, I think the recommendation is like around 25, I think, for healthy weight, or less than 25, because I think the risk of diabetes and associated complication goes up around 27. So I think you're probably okay, but I wouldn't do more, and I would focus on muscular weight as opposed to fat weight.
So I have one more question. So he's been, his CA was undetectable since over a year, and his CT scan is all clean. So we haven't had a chance to do the signatera testing. I don't know if we saved but if we don't have a physical tumor to test from, then we cannot get it. And another thing is that he's been on Keytruda, Herceptin, and 5-FU. And next March will be 2 years, and our doctor said 2 years the max, and she has to decide what to do after. So I like to hear from this expert opinions. And he could tell himself, because he's a physician, but he doesn't want to ask questions, so I'm stupid and I have to ask questions.
I will say what's really weird is since I've been sick, my golf game has improved. It's very bizarre. But, I'm swinging easier, freer, even with some peripheral neuropathy. So I don't know what that's about. Yeah. In fact, when I go to see my oncologist, I see her every 3 or 4 months after my scanning. She always asks me, well, how do you feel? I said, fine. I said, I play golf. She says, how many holes? I said, 18. And she's like, 18 holes? You play 18 holes? But I tell her, yeah, I'm actually playing better. But initially with the oxaliplatin, I had peripheral neuropathy, but we stopped that. But I still have some, but yeah. But yeah, I think her question is she said that Keytruda is usually for 2 years. So she said she has to think about what to do at that time. So what are your thoughts about that? And I mean, obviously I'm doing well now, so she might just say continue, but I don't know. What do you guys think? Yeah.
Get one of the medical oncologists. Don't look at me, I'm a surgeon. Yeah, so I mean, knowing this, and there are recommendations and guidelines and studies, and then there is practice, like the 5 years of Keytruda,
So I mean,
stage 4 cancer-free, right? Yeah. So
So
Dr. Wainberg?
challenge. So first of all, you should definitely. This is a good tagline for Keytruda and Herceptin, that it actually improved your golf game. This would be the most effective marketing, especially for doctors, right? But I think that, the studies, most of the studies don't have, the reason 2 years is there is because that's what they used in the study, right? So 2 years is what the study used, so therefore we're not going to make a recommendation beyond 2 years. So, and most studies, new studies, haven't done a great job, particularly in this cancer, of analyzing whether we need all that 2 years and whether 1 year is enough, or better yet, what do we do after 2 years? Can we stop the drug? And part of the point is that, there's a little apprehension about stopping therapy, right? We all know that. We acknowledge that reality. We're nervous about what happens. Obviously, the patient's nervous, but certainly the doctor's nervous too, because we don't want to be in a situation where we say, hey, gosh, let's stop this Keytruda that's been, working, or we think is working for the last 4 years, and now let's stop it and see what happens. And so there's a little bit of apprehension on behalf of both the provider and the patient. And the studies don't answer the question. Or they answered a question actually in other cancers, interestingly, in melanoma and lung cancer, where Keytruda has been around for a lot longer. There have been studies that have shown that you in select patients don't need all that Keytruda, and you could discontinue it at some point. And there's no reason not to think about it. But we haven't done those sort of what's called non-inferiority studies in gastric cancer yet. We're trying to. Dr. Iqbal's actually trying to lead a study, or trying to organize a study that's going to address this, particularly in the, not so much in stage 4 maybe, but in the perioperative setting. Do we need this full year of immunotherapy in every single patient? So I think for individuals, it's got to be an individual decision. It's got to be, the doctor won't be able to give you the absolute right thing, and it's going to be a little bit of, anecdotal experience from that individual provider and what's right for the patient. For example, in some of my patients where I have treated them for over 2 years with immunotherapy, in select patients, I start to feel very comfortable stopping the drug. and watching it. But it really depends a little bit on the biomarker, a little bit on the individual characteristics. So,
Can I suggest something crazy, maybe? Have you had an upper endoscopy in a diagnostic lab to show? I mean, do we know that this is completely gone, and is it based on CT alone, or? Yeah, I wonder if something like that, if you're gonna stop therapy, I would want to be a little bit more certain that everything is gone. And CT scans, especially after immunotherapy and HER2 Herceptin therapy, they may be a little bit more deceptive. There's fibrosis, etc. The other thing is, if there is tumor left, and you can biopsy that, we hope there's nothing there, but if there is, maybe the biomarkers will tell you whether or not you're even benefiting from any more Herceptin. Maybe the HER2 is gone, or the PD-L1 expression is no longer there, or something else is there. So, and then it also could be that if there's something there and you test for Claudin or FGFR2, then you have options for a clinical trial. This is all on the assumption that the cancer is gone, and you look fantastic, and it looks like you're in good health, and it sounds like the cancer is gone. But
I don't think she actually, in the beginning, was thinking that far ahead. I don't think she thought that I would have to deal with this into
yeah, so I think this is a great dilemma, right?
To be honest, I didn't think she thought I would still be here. I think that was really,
Yeah.
It was between the lines, but I thought, and being a physician myself, I don't really blame her. It was really bad.
Yeah.
She said, oh, I have to think about it.
But I think we will see more and more of patients like you, where we will be in this new era of targeted therapy responding super well in certain patients, and multidisciplinary care will be very important. The last question before.
Can I
go
add
ahead.
to this?
Actually, yesterday we were here to hear some of your stories. I think it's very encouraging. But on the other side, this really highlights the biomarker-driven therapy, because one patient MSI high, and then even she is very young. Yesterday, the speaker, and then we are happy to see her. She's fully recovered. And one case with 3 kids, right? So she's fighting with HER2 positive gastric cancer. She's doing very well, able to come to the conference, and then we heard his story. So again, emphasize biomarker-driven therapy.
Okay, I like to add something to this. Immunotherapy. After 3 years, for 1 year, my ctDNA was negative. So the oncologist and I were thinking about this. What do we do next? Do we stop? Or do we keep going? And so there was no data at the time for 3 years or more. What's the consequence? I don't have much side effects, so I told him, let's go and stop the KEYTRUDA. And 6 months later, the cancer came back. So went back on the KEYTRUDA, and 6 months later, the cancer was gone again. So in my case, I have no choice. KEYTRUDA is the only thing that keeps me. I cannot tolerate the chemotherapy anymore, or at least I haven't tried for a while. And when the lymph node shows up here or there, so just radiate it and just keep going. That's what I've been doing now for 7 years, and it seems to work. And my tennis game got better over time too.
I think that's what you're saying. It's a really good point, and I'm hearing this, and I hope we're all understanding this, that it's not a one-size-fits-all approach, and we're here to learn from each other and learn about all the potential approaches out there, but your therapy should absolutely be tailored to your care, to your tumor, to your condition of your body, and hopefully you find your quarterback who's guiding you through your care so that you can get opinions, you can see other disciplines, but that you go back to your person. Because I always tell our patients that my job is to educate you and then you're making the informed decisions with guidance from your team. So, and then it's hopefully the quarterback on your team. So yes, there's so many clinical scenarios that, you know, what you've mentioned and sir, what you've been talking about, and what our folks, our experts have said. We don't have data for every clinical scenario. So a lot of what we do is extrapolating from other tumor types, extrapolating from, you know, the data that we do have, and then also talking to our patients, informing them what we know and what we don't know, and then tailoring the care to what's comfortable for both you and us as providers. So, okay, and with talking about tailoring therapy, we're going to move on to actually biomarkers. And we've had a great session this morning from Dr. Boda about looking at minimal residual disease. But biomarker evaluation, as you all have heard and know, is critical now to the care of esophagogastric cancer, not only in the advanced disease setting, but also in the localized setting. So perhaps we can start with your experiences with biomarker evaluation. Did you feel like that was explained to you? Do you feel like you guys got, you know, you as patients got appropriate testing and understood the implications of that testing to your care?
This is the first time I've been to one of these conferences, and until today or yesterday, the ctDNA testing I had never heard of. I had stage 3 stomach cancer in 1989, and I think, Dr. Iqbal, you may remember Dr. Cynthia Gale-Leichman.
Yes,
I don't know.
I do,
So
yes.
she was my oncologist, and I was in a small clinical trial then, because I went to her for a second opinion, and the other doctors wanted to just operate. And so she gave me chemotherapy before surgery and also after. And I'm a 37-year survivor.
That's amazing,
So
yeah.
But at the same time, she recognized that I probably had a genetic. It was years before they had the testing for Lynch syndrome. But I tested positive for Lynch and have since then had lung and ovarian cancer. And then this last year, I had stomach cancer again. I had Billy Roth 2 in 1989, but I had 10% of my stomach left. So February, or in December, I got diagnosed with stomach cancer again. And they're not sure if it was a recurrence or a new disease, but it was stage 1A. And so I had the rest of my stomach removed. But I'm just wondering, should I have the ctDNA testing because I didn't have any treatment, so I'm just done. But I've had such a long history with cancer. I want to be proactive.
Sure.
So it's really, that's all of that just for that question.
Yeah,
Should I have the testing?
Well, I'm glad you're doing well. That's a great question. So perhaps we can go to our panel, and can you talk to us about what's standard and what's not standard? Because I think people are becoming, you know, as a patient, if I'm hearing about new technology that may or may not have data to support its use, and some physicians are saying, that's not what I do, and others are doing it. What should we be doing? What should I be doing if I was a patient? What do you all consider standard approach, standard testing? June, do you want to just go down the...
Sure.
Dr.
So,
Gunn.
no problem. So standard is really, there's some nationally recognized consensus guidelines, evidence-based tests. That includes some standard blood tests, history and physical, imaging, usually, you know, CT or MRI, and usually they throw in some endoscopies as well. And a lot of these are symptom-driven, especially when, congratulations again, when you're really far out in the later stages of surveillance. Those are what we call more standard tests. I would say ctDNA right now is still more in the experimental side. Even in other tumor types where they've had a little bit more traction, longer time of study, For example, colorectal cancer, where I do research in ctDNA, the guidelines still don't recommend this as a standard of care test. So we have to really be careful in advocating for such tests. One such way that I do encourage patients to consider is if there is an investigational study, for example, a trial or an observational study, then that's something I think I support in that sense if there was a ctDNA-based study. But that's just my experience so far with these ctDNA assays.
Zev, what do you think is the standard biomarkers that folks should be asking for or make sure that they've been assessed?
So, I mean, I think for people with advanced disease, we have, all the typical proteins that we look for in every patient, which includes HER2 and PD-L1 and MMR, which is a way to check for MSI-high Lynch syndrome. So those are kind of now routine and standard. Claudin 18.2 is another one that people consider to be routine and standard. PD-L1 is now tested in a number of different ways, but that should be part of it, definitely. So these are the, what we call, I guess in advanced disease, the 4 essential biomarkers for determining what treatment a patient should get on the targeted therapy front, not on the chemo front, of course. In earlier stages of the disease, this is, a little controversial. Some people don't do it at all. Some people do MMR by IHC for MSI high and PD-L1, and some people do everything just because you can get the information quickly. So it's somewhat controversial in early stage gastric cancer at the moment. I think there's another way that some people send the sample off for NGS and next generation sequencing, which kind of gives a lot of that information in a different way. So there's a whole bunch of different ways in which people consider it to be done.
Mark, did you want to say something?
Well, yeah, I was going to ask the question to my colleagues around the table here. When, I think Zev gave a great summary about the molecular testing that's done. And then when do you make the decision, you alluded to it at the end, to do NGS, which is next generation sequencing for these cancers? When do you guys make that decision? What goes into that decision for you all?
Danny, did you want to take that?
Yeah, so to answer your question about when the NGS should be tested, I think any stage 4 and unresective gastric cancer come to our center, so should be tested for NGS, at least those kind of IgG staining, including what Dr. Wainberg said, based on the NCCN guideline, these markers should be tested because in the first line, they will triage your treatment, either immunotherapy versus zolbetuximab, and then we'll also have a HER2, because these markers definitely can help you to improve your overall survival, right? So in terms of your question about how many times we should test, I think usually we use the primary tumor to test, but we know there is a discordance with primary tumor and the metastasis. And if you have a disseminated tumor in the bone, in all different areas, maybe it's valuable like liver. So maybe we also, after treatment, you don't see response, you may also consider rebiopsy those tissue lesions to see whether they lose their marker, they change their marker, or they have different entity. We do see primary tumor HER2 negative, but the liver can be HER2 positive.
So, I mean, in terms of ctDNA, I think what we're hearing is that, just specifically to your question, is that it's not standard of care. And that I think all of us are academic oncologists and surgeons, and so, I think sometimes, not sometimes, but a lot of the time we incorporate things into care that don't have, randomized trials that support it definitively. I mean, I think it's been adopted by many physicians. I think it's a reasonable thing to follow, but with all the caveats that you heard this morning, this, depending on the sensitivity, depending on where the recurrence is, and then what to do with a positive ctDNA. I think it's just another prognostic marker like your CEA. We would continue to follow it, perhaps look more frequently, perhaps do that laparoscopic look. Maybe the surgeons can talk about, because that's usually a high risk area for recurrence that we don't pick up on scans. But specifically to the ctDNA MRD question, I think a lot of us do it, but it's not a NCCN guideline-based standard of care option. And then I think you had a question earlier about, can you still do ctDNA because he doesn't have tumor? They can use the primary tumor, the original biopsies, but I think the point was made that, and you heard the point again today, is that sometimes the tumor starts to lose these markers, particularly HER2. So that would be a reason to rebiopsy, or consider looking at circulating tumor cells instead of rebiopsying. If we don't see any place to rebiopsy, perhaps use those cells to test to see if that expression is still there.
Sorry. May, kind of going back to this lady's question. So I think you had cancer back in 1989. I think standard surveillance, I know the biomarkers are, the kind of the new thing, coolest thing. I don't think you'll know your biomarker from 1989. But standard of care for surveillance is a good history, right? A good exam. You already passed. I think normally I follow my patient for about 5 years for a symptom. Any suspicious symptom, I do scope them for 2 years. After that is whenever they have symptoms. One of the things that I do think is something that maybe we should be a little bit more aware of is the Bell-Roth-2 connection that you had. It is the one where your biliary tract is still it's looped back to the stomach. So this connection has a little bit higher risk of a bioreflux. I don't know if you heard of that before. Those are a little more ulcerogenic, and they have a slightly higher chance of potential. Anytime you have chronic inflammation, you may have risk of cancer formation. I do think, and I have seen it in cancer cases or not cancer cases of B2 that has malignant transformation. So I do think if you did have surgery, and then B2 was done a lot, and it's still been done. And I think for these patients, perhaps maybe every few years to go back and take a look at anastomosis, is the ulcers, may be a good thing for survivors who had a gastrectomy.
Go ahead.
In her case, just to follow up, she had the stomach cancer stage 1B. Now, does she need to have a set of biomarkers just for that? Because her cancer in 89 would not be the same as...
Well, what I heard was that you're MSI high and that you have Lynch syndrome. So
the Lynch syndrome is a little bit of a blessing because I get a lot of surveillance. I get colonoscopies every year and endoscopies every other year. So, that, even though it's a burden, it's also a blessing.
That
Yes.
It's a blessing So that was what put her at risk for developing the cancers. Yeah. I saw some other hands. Oh, of course, yes.
Yeah,
and then we can.
I have actually two questions. On her case, she has had multiple type of cancers. I mean, with ctDNA, how do they do the profiling? Do they create different profiles for each different tumors? And if it comes back positive, how do you know of which? That's my first question. And the second question is for the biomarkers of in cases where you can have, say, PD-L1 positive and also Claudin positive, do you get both medications since they're not FDA approved, or how do you choose which one to go with, immunotherapy or zolbetuximab?
Frank, great questions. Both of them excellent questions, which we're not going to have answers to. Does someone want to, Maggie, did you want to take the first one, the ctDNA question, or does one of the medical oncologists want to take the ctDNA question? Whoever's comfortable. I don't want to be the only one talking.
I think that's a...
And then maybe the second question we can take to the medical oncologist.
Yes, exactly. I think that's an incredibly thoughtful, insightful question. Amazing that you are processing the fact that a patient has 3 different cancers. And when Dr. Boda presented, the concept of ctDNA, there is two different kinds of ctDNA. One is the tumor-informed ctDNA, which takes into account the changes that are happening in that individual tumor that the patient has, and a profile has been created to that specific tumor and that specific tumor's biology. That is the tumor-informed testing called the signatera testing, or the one that we commonly use. There are many, many, many. I'm not here advocating for signatera, but signatera is a tumor-informed testing. The other forms of testing is called as tumor-agnostic ctDNA testing, which is looking for general common mutations or abnormalities that would be present in any given cancer. So that would be the KRAS mutations and other things that we look for, right? So typically, the scenario where a patient has two cancers that are active is unusual. So we don't have information about as to how best to approach those patients. So typically what we are dealing with is a patient who has got a cancer, in whom, based on the availability of a tumor, you can decide as to whether you're using the tumor-informed assay to look for MRD or molecular residual disease or recurrence or progression or response to treatment, depending upon what you're doing it for. Right? That's the most common scenario. But in situations like this is where the art of medicine comes in. Are you going to try and use in whichever tumor the tumor-informed assay, and would you be doing another tumor-agnostic assays for the tumors for which you didn't have that established profile set up? It is definitely an art at this point. I don't think any one of us would have definitive answers, but that is how you think about how do you get the best information and which information is going to be the most relevant based on the stage of disease and what is being currently active. Even though the patient may have history of cancer, what is that you're going after?
Great.
I think the good news is that you had a very early cancer, as somebody else pointed out, and found on surveillance, and all of your stomach that was at risk for the cancer is now gone. And so the likelihood of that gastric cancer coming back as a distant metastases, especially in your MSI high tumor that was T1B or T1A, is exceptionally low. Yay. So, I mean, we got to celebrate the wins, right? You lost your stomach, but you're cancer-free, and probably from stomach cancer, it's unlikely that it will come back. And so the rate-limiting other cancers may be the focus of your surveillance.
Okay, and then Dr. Wainberg ran away with this before the second question, which is the more difficult question, which I think is a question that is plaguing us as GI oncologists as to what to do. So maybe June and Danny, you have a patient who's Claudin 18.2 positive and PD-L1 positive. How are you handling those patients?
Volunteer to exactly. Thank you for asking this question. I think like 1 or 2 years ago when you were on the SWOG, people ask you the same question from providers. I think there's a lot of questions about on the first, at the first line therapy, either you go by PD-L1 above 1 and then Claudin 18 75% because you have options, right? But as a provider, how you sequence this treatment, and it really depends. And we look at the PD-L1 level, right? If it's a patient's 10%, the Claudin 18 just cut off 75, and the patient has a lot of GI symptoms and the belly can take anything down, at that moment, I believe most of the community oncologists will go for chemo and IO for sure, because that's a survey I got from my colleagues in the community. On the other side, so like patient has a high Claudin 18 expression and the GI toxicity is not your concern, and the PD-L1 maybe 1 to 2%, you may go for zobi with chemo first. But the other thing is in the second line, we talk about access to care. If your center does not have a clinical trials like Claudin 18 driven therapy, and then also you don't have a second line for IO, so you really need to think about how we can maximize those treatment option sequencings. And we just recently did our single center analysis. We find a very interesting phenomenon, just like the high Claudin 18 positive patients may have a relatively lower PD-L1. However, and then also there is a discordance between primary tumor and also metastasized. The PD-L1 can be different and the Claudin 18 can be also different. I don't know.
June, did you have anything to add, or?
No, that's a great answer. That's why I always call Dr. Castillo for all my tough cases. Yeah, but I certainly agree. I think it's a very important patient-provider discussion about the pros and cons. It depends on your biomarker, how intense one is relative to the other. Side effects, patient symptoms that may play a quality of life impact on this, and I think that completes the whole discussion in the office.
So again, so to summarize, so the biomarker evaluation, the level of marker, the side effect profile of the antibodies that you may be getting, thinking about if you have high disease burden, what the response rates are with some of these drugs versus others. So for example, the response rates are different between the antibodies when they're combined with chemotherapy, and then the dilemma we have is they're all approved only in first line. So that second line issue becomes a real one if you've got insurance companies that are guiding how we can give treatment or preventing patients from getting immunotherapy in a second line setting, if you will, or vice versa. So that becomes something that we actually have to take into account as well, as where are we going to get the biggest bang, the best outcome the first time we offer treatment. And then again, an informed decision with the patients that these are the side effects. This is what are you willing to tolerate and go through, and does this go along with how you see your quality of life?
I actually have a question about the sequencing. If you give a patient FOLFOX and Nivo and they progress, insurance companies don't approve Zolbe as second line and vice versa. Is that correct?
They're both approved only first line.
For first line.
Yeah, so all the immunotherapies, the trio, are approved in combo with chemo first line. And then Zolbe is also in combination with chemo first line. You had a question.
Oh, okay. I guess it kind of goes with everything that we've talked about this morning. But first of all, I really appreciate all of you being here. I know we all do. As somebody said, I know that we give you hope. You guys are here giving all of us hope. So to share my story, I know I've spoken with a few of you already. So I was originally diagnosed in 2021. I had a large mass at the base of my stomach, which was making me very, very sick. It was covering my pyloric sphincter. I was originally diagnosed at a stage 3 because when they went in to remove my stomach, they found that I had lymph node involvement. Fast forward, so I'm BRCA1, and I do have a low PD-L1, so at least that opened me up to immunotherapy. I have done the PARP inhibitors. I have probably done just about everything at this point. So originally diagnosed in 2021, did 4 flat, did 80% of my stomach removed along with my gallbladder. Fast forward, so because I'm BRCA, my oncologist, and I'm gonna have to say my team has been amazing. I was very, very blessed with the GI that I went and saw, and they put me specifically to somebody that was a specialist in stomach cancer. Sorry, I'm a little nervous. But so fast forward, he was...
You're doing great.
Thank you. He was very diligent in monitoring what was going on inside my body. And we had a weird PET scan come back at the end of 2023, and he's like, you need to go get your ovaries removed because you're BRCA1, you need to do it. And I will tell you, I went kicking and screaming into that surgery because my surgery for my stomach removal was so just intense. And, I finally found an OB/GYN, an oncologist that was amazing. And I like to grasp the knowledge. And I think everybody that's here is very much like that, is we need the education because I want to know what I'm doing for my body is the right decision for me. And what is my outcome gonna be? I'm 42 years old. I was diagnosed at 37. my mom had breast cancer. My family history is with breast cancer. That was what I thought my cancer was going to be, and it has not been that. So fast forward April of last year, I went in and had a total hysterectomy, a 1.5-hour surgery with one surgeon turned into a 4-hour surgery with 2 surgeons. They brought in an additional surgeon. Why I say I'm blessed with my team is because they could have easily, when they went in and saw that I had a reoccurrence in my ovaries, in my tubes, it was on my peritoneal, it had spread. They could have easily closed me back up and said, good luck. And they didn't. So they proceeded with the surgery. I came out of that and I started on Folfox, and they started with me with immunotherapy. So I'm on Keytruda, currently still. I went into my oncologist, and as soon as I found out that I had peritoneal metastases because of things like this and the education that I've had and the ability to have access to people like you, I went into my oncologist and I go, okay, so we have peritoneal spread, we're doing HIPEC, right? And he's like, slow down. Slow down, let's get you on the Folfox, we'll see how your body responds, we're gonna go step by step. He did get me to someone through MD Anderson. I'm in Phoenix, so MD Anderson Banner facility in Gilbert, Arizona, is where I ended up doing my HIPEC. So I had 2 HIPEC last year, so I had a PCI score of 10, and I had my first laparoscopic HIPEC done in September. 5 weeks later, he had me come in for HIPEC with CRS. It had spread, I did a splenectomy. It was on my liver, all over my spleen. He removed 2 feet worth of my bowel. And I will tell you, that was probably the hardest surgery to recover from, and I still don't think I'm fully recovered, and it's a year later. But we came out, and I've been NED since November 6th of last year. So I am stage 4. So I'm stage 4, but I like to come and do these things because I want to spread hope just as much as you do. And honestly, speaking with Dr. Wu, speaking with the signatera gentleman, it helps solidify that my team is doing what's right for me. And I think we all need to be comfortable and confident and solid in our decision-making with our team. Like you said, we need to have that cheerleader. We need to have that person that's behind us. And I will tell you, I saw my oncologist on Friday, and I cannot say more good things about who I have been seeing for the last 4 years. And I would love to get him. I don't know if he knows any of you guys. He may already, but
You can say your oncologist's name if you want.
So I'm being seen at Ironwood Cancer and Research Centers in Phoenix, Arizona, and it's his name is Dr. Kamadi, Sujith Kamadi. So I don't know if he probably, I don't know.
Trying to make friends. So we need to know as many great medical oncologists who are treating gastric cancer in this country, especially outside of California.
Yes, I would love to connect all of you because, like I said, he is my heart and soul. And I will tell you, if it wasn't for him, I don't know if I would be here, to be completely honest. And so I hope that everybody here this weekend really is just, I mean, we can't get past the hope, and hearing all of the great things, the great panel we had yesterday, we all grasp with the knowledge you have, and not everybody gets the opportunity that we do to sit and listen to you and talk. And, but yeah, it's definitely been, I love all of you, and I don't even know you.
If I can make a comment regarding that, it's really, and you alluded to this, and I'm sure the rest of the panel will agree, we do this for you all because we care about this disease and you as patients so much. And so that's why we're here. So this is, at least for me, and I imagine my colleagues here, that this is very inspirational to us to see you all here going through what you're going through, fighting the good fight and coming through. And so it's really our honor and our gratitude to you guys, not as much the other way around.
And we learn from you as much as, we're sharing our experience and how we get better. Is learning from how patients respond. When you tell your story initially, I'm like, oh, you had what surgery? Like, who did that? Why did you do that? And I don't know if at the time, you know, all the decision would have been same, but then we learned that you're here doing so well because you have you got the cancer because of the BRCA, but then because of the BRCA, the responses have been amazing. So as we were talking patient-specific and the experiences that you bring to us and you share with your courage and your bravery, actually, I bring that back and enriches our experiences. So the next time I see a patient like yourself, I'd be like, wait a minute, you know, maybe this may work, right? So some of these, this is the art of medicine that we were talking about before. Dr. Senthil and the whole team were always talking about art of medicine, because we have the science and then it's the experience that you guys give us that allows us to do better the next time. So thank you.
Thanks for sharing that, yeah. Are there other questions or, oh yes, go ahead.
Hi there, my name is Aki Smith. I have a question for the patient advocates, Jason and Frank. You guys have been sitting on this panel with these amazing doctors. Do you guys have any thoughts of what they've been saying?
At least for me, I mean, I've learned a lot, quite a bit, and a lot of it goes over my head, but, you know, I guess it just, it gives me something to take back and maybe, you know, provide support to those people that are not able to attend the conference or, you know, just online support groups.
So follow-up question for Frank, and then go to Jason. I mean, what are your thoughts? Do you feel like you have a multidisciplinary care with your team of doctors, or what are you going to take back?
Yeah, I do go to it's like NCI hospital, and usually they do discuss, I guess, my treatment with surgical oncologists. But I think all my discussion is straight with the medical oncologist. I never really actually had any conversations with the surgical, so he just tells me that he's discussed it. You know, I just take his word for it.
So do you have a question for the surgeons then, in your case?
Yeah, I do have a question. Actually, I think you guys did talk about this. You know, I'm stage 4. I was diagnosed last year in March, and you know, I am PD-L1 positive, and I've been on immunotherapy and chemotherapy for 1.5 years, and I've been NED for I think maybe 6 months or so. And I usually get surveillance with EGDs, PETs, and and what else? And signatera as well, and they're all being negative. So I've had asked about, you know, whether it's worth to even consider surgery, and, you know, obviously I think about it, waiting that, you know, do I want to stop treatment, you know, do surgery, and then go back to treatment, and the risk with that, and it's a big operation. And so I think somebody did ask this question as to, you know, do you even consider surgery, right? In like because I guess it's a case-by-case scenario where some patients, I have talked to some other stage 4 patients that they have had surgery, and some of them haven't. I think somebody said that, so I guess is how do you make the decision of whether somebody, you know, you can restage them and operate on them on the stage 4 setting?
Yes. You know, first off, I do. $1 million question, Frank. I do want to acknowledge, you know, Frank, the questions that are coming out of this type of a group, you know, from patient advocacy group, is extremely crucial for us. It's because this is what we take back and ask. You know, these are some of the questions our patients are asking. how can we better answer these questions? So although we may not have answers to your questions, it's inspiring us to think deeply, answer the questions that are most relevant to our patients, right? So this has been wonderful. I would say all of you are so bright. And some of the questions we are like stumped by, this is exactly what we are talking about. We don't have answers to this. You know, this is very complex. And so you have all been great and helping us also focus on areas that we should be focusing on. The second, to answer Frank's question, when is surgery appropriate in a patient with stage 4 gastric cancer? Right? It is not simple to make that decision. I would say it's probably one of the hardest decisions that we collectively, as a multidisciplinary team, will make because there are significant pros and cons to either one of those approach. Particularly, surgery is such a definitive event. Once you've done it, you've done it. There is no going back. Whatever you took out, it has been taken out. There is no going back. Right? And it has to make a meaningful improvement in a patient's survival. That is what you're asking, right? So whenever, it is true for any cancer, let alone gastric stage 4 cancer, the question is, will surgery add meaningful benefit to the patient's overall outcome, specifically survival, along with a reasonable quality of life? I cannot underestimate the importance of quality of life when we are managing an advanced stage 4 cancer. It's crucial for the patients, right? The treatment shouldn't be worse than the disease itself. So we are making these tough decisions. And there are clinical trials that is trying to answer this question systematically with appropriate selection criteria. And yesterday I had the opportunity to introduce STOPGAP2 trial, and that is specific for patients with peritoneal carcinomatosis. So we are not talking about patients with liver metastasis or lung metastasis or bone metastasis. We are trying to study piece by piece and figuring out as to when surgery would add meaningful improvement to a patient's survival. So these are tough questions, and that's where the multidisciplinary care, patient selection, customization of treatment, understanding the biology, and being thoughtful and having that shared decision-making aligned with the patient's own goals and objectives, and that is how we have to make these tough decisions. But there is no one blanket answer that fits any patient.
Also, I think the site of stage 4, the distant metastases, does matter. And it's different. So if you had 10 liver mets versus 1 liver met, considerations are different. Like we talked about a lot about PCI scores, where you end up with the PCI score. If you have a 39 and you end up at 39 after systemic therapy, you start at 5, but it goes to 25. Or you start at 15 and it goes to 0 with systemic therapy. So the questions are, not just whether or not to do the surgery, but also the timing, where is your tumor, how was your response? And we talked a lot about biology, right? And when making decisions, not just for chemotherapy, but biology also dictates whether or not even surgery gets on the table for most of us, and absolutely patient-specific. The trial results are very mixed, and even if you have like a curve, most patients do not benefit. Some patients benefit. Like, who are those patients who benefit, right? And we were trying to figure out this very tough question.
100%. So we just go back to the tailoring, and it's identifying who is going to actually be that patient who's the outlier, like you mentioned, who's going to do well with these therapeutics. Because the way we make decisions is by doing randomized clinical trials. And so this is, again, where it comes into the art of medicine. I also want to mention there was just a clinical trial that unfortunately closed due to lack of accrual, but was looking at, instead of operating on metastatic sites, could we radiate all those metastatic sites to kind of effectively give local therapy as, as surgery would potentially to to the residual disease in patients who, have limited disease that's left. But unfortunately, the trial didn't accrue, and so it just closed. But there's also some data around radiating the residual sites after chemotherapy. So with similar outcomes to what we're seeing for those tailored patients for surgery as well. So
I
I'm
want to
sorry, Sharon,
have
were
a
you going to say
follow-up
something?
question. So
Yeah.
for Frank's situation, I know he said he never talked to a surgeon. In his case, would it be beneficiary for him to speak to a surgeon who has experience in conversion therapy, surgery after, to kind of review his individualized case, just at least maybe put his mind at ease, perhaps?
So Frank mentioned that he is at an NCI center, right? And typically in an NCI comprehensive cancer centers, there is just the nature of how cancer care is rendered is multidisciplinary cancer care and involving tumor board discussions. So and these tumor boards are very valuable where surgeons are present, multiple surgeons are present, and they are able to review the patient's history, the pathology, and the radiology, and they're able to render a fairly definitive opinion as to what would be the surgical option. And if there are further questions, of course, a surgeon would be happy to see. So I don't want to cast any doubt about as to how well you have done, and your doctors are probably seeking that guidance from the other doctors, including your surgeons, and giving you the guidance. But if there are further questions, I'm sure they will be happy to offer a second opinion. Having said that, the one option is if there are information that a patient is hearing and they're bringing back, and which I have seen often in a patient's clinical condition, is that even though it's all well intended, sometimes the information has not permeated to that specific physician. Often doesn't happen in an NCI center, but in the non-NCI centers where maybe the information has not permeated and they hear about a particular trial and the patient goes back and says, hey, I heard about this. Am I a candidate? Could I possibly hear a little bit more about it? That's an opportunity for a second opinion also, right? So it's not that it shouldn't, the surgeon's opinion in a multidisciplinary tumor board is sufficient. It should be in an NCI designated comprehensive cancer center, but however, in other places, maybe the surgeon is not as familiar with all the approaches that can be offered in a stage 4 setting. So we have to keep that in mind. Is that opinion is complete? Do they know everything that needs to be done for a stage 4 cancer? If not, seeking a second opinion in a more advanced center or with a physician who has the training or has that niche practice where they manage stage 4 cancer is crucial.
So Frank, I have a question for you. Do you want to go see a surgeon? I think it's sort of your decision, right? If you want to see a surgeon, I say ask for a referral to a surgeon and go see it and put the question to rest. Or it's something that surgeon may follow you over a course of time and find that at some point that they may intervene in some way, whether it's curative or not, to help you along the way. So I think it's sort of your decision, and you can ask the medical oncologist to refer.
I guess.
He asked us tough questions. I'm just throwing it.
Yeah, for me, honestly, I do trust my medical oncologist, and he did say that he talked to a surgical oncologist, and I take his words for it, right? So I guess it's more of just curious whether I should consider it, right? I mean, like she said, it is a big change in quality of life. So to me, it will have to be worth it to even consider it, right? So it was more for informational and just to get a second opinion.
That's a really good response. I can't help but think about when I do something in my house, right? Like if I'm going to redo part of my house, my wife, I don't just take the first contractor's estimate. It's going to take this many dollars and this much time, not just because of my wife, but for other reasons. We get like 3 or 4 people coming in and giving us estimates and things. So I think when I think about the way I do my life, how I do my medicine is also similar. And so I think that's one thing. And the other thing is, yeah, trust is an important thing to build with your team. I think you have tremendous trust with your team, and that's sometimes that's almost more important in many ways because the outcome is going to be the outcome. But if you feel good about the outcome with your team, that means a lot. Frank, Jason, thank you guys very much for being so collaborative in this discussion. I really appreciate it. I've been handed the task of getting us through the next few minutes. It says 40 minutes, but it's maybe it'll be 30. We'll see. So panel 3 is bridging institutions, coordinating care, and expanding access. And the focus we were asked to talk about was exploring how leading centers can better coordinate referrals, share knowledge, and improve access to multidisciplinary expertise, ensuring patients benefit from advanced care regardless of treatment location. And so, yeah, it's a pretty big charge. I'll start with our patients here. And right away we have a couple. Great. Any thoughts or questions about that specific topic?
Yeah, I wanted to, so my name is Emmy. I was a caregiver to my husband, Tay. We were seeing at City of Hope with Dr. Wu and Dr. Chow. Tay was actually Dr. Bada's case study of the patient that had exhausted all options for his cancer. You saw on the chart, he did every line of chemo. He got serial HIPEC with Dr. Wu. This is back in 2020, and he really pushed, Dr. Wu knows, he really pushed to be able to have serial HIPEC done at City of Hope for gastric cancer when it wasn't done there yet. And so he kind of opened it up for everybody there since then. And he also went through every line of chemo. He did Herceptin, Keytruda, and then he went on the CAR-T clinical trial with Dr. Bada, and we were doing ctDNA to track how well it was doing. And so my question is, or I guess question, comment, we were fortunate enough to, and actually, sorry, later, he did a clinical trial with Dr. Wainberg for a little bit. And so we were fortunate enough to be seen at a major cancer center. Dr. Chow was, I know a lot of you guys, know him well. He was well connected, well informed about everybody's clinical trials in the area. We explored IP chemo for a bit, and Dr. Chow was like, well, we're not doing it at City of Hope, but, ask, my colleague, Dr. Dayani at UCI, look into it with him. And, so he referred us to talk to Dr. Dayani. And again, we didn't end up pursuing it, but, we were lucky that Dr. Chow kind of was in the know with, what his colleagues were doing at all the other kind of major medical centers in the area. And also, even with clinical trials, he knew what Dr. Wainberg was doing with all his trials, and because he was Claudin positive, and so again, we were fortunate that Dr. Wu and Dr. Chow, we had this amazing team that I am just, I don't have the words, right? But I always wondered, for other people, other patients who aren't necessarily being seen at kind of these major medical centers, and how are they finding out about who's doing what clinical trials, and being able to kind of refer their patients to and again, similar to like IP chemo, knowing what everyone else is doing if they can't get that done at their medical center. So I guess that's kind of my question for everyone.
It's a good question. So in essence, you were very fortunate to have access to people who had great relationships in the LA region and nationally. Yeah. We have a lot of patients. How have other folks in the audience found clinical trials? If we talk about it, first of all, actually, maybe a better question would be, let's make sure we all understand what a clinical trial is. Can any of our panelists help the audience understand?
Oh, I think this audience.
Yeah? All right, you guys got it?
This audience has got it.
All right, well, we're informed. How do people find clinical trials? In the back, we have somebody raise their hand. Go microphone for Bar. Someone's going to get to you quick. Don't trip.
This is very timely because I'm now in the stage of looking for clinical trials. In the beginning, it was just Googling clinical trials and then recognizing clinicaltrials.gov and different websites to find that. I've been part of a couple studies, surveys, and focus groups testing out clinical trial websites and kind of realizing that there's just a lot of people trying to make their own version of helping you find it. These days, I use ChatGPT and ask, for those. And just recently, last week, I realized of a benefit through work that connected me with Massive Bio, who also uses AI to connect patients with patient-specific clinical trial offerings. And I talked to Dr. Castillo as much as I can about what she thinks the next clinical trial could work for him. So I feel like there's, once you get into this world that there's clinical trials and you want to find what works for you, there's all this information. And you're still, as a patient and caregiver, left in a place of, okay, which one do I choose? And as a patient and caregiver, it's still a scary space because when I think clinical trial, I think testing that is uncertain. And I'd rather be certain about what the treatment is going to be. And I feel like it would be great, I know it's not possible, but it'd be great if somebody was like, oh, this is the trial for you. This one's made for you. It's the right situation, right biomarkers and everything. But kind of that's, I guess, patient caregiver experience. So we're still looking for the clinical trial to join. And then maybe I just wanted to throw this out there as a quick question. Somebody had mentioned before about if you're on Nivo and you progress, then you don't get insurance for Nivo. Is there still the company will give coverage in some cases? 'Cause I know yesterday when Arusa was sharing her story, she couldn't get her immunotherapy covered, but then they went straight to Merck and they got it covered, if that's been a case for you all.
You asked really good questions around clinical trials earlier in the day too. So what's unfortunate is it is a lot of muddling through NCI.gov, clinicaltrials.gov, or relying on your providers to have the relationships. I mean, in LA, I think generally the GI oncologists are friendly to each other. And you mentioned Joe Chow. We used to talk regularly or meet, and when we're at meetings, we know which site has what trials open or talk to each other when we have patients who are progressing. Zev and I often see the same people. But it is a huge problem as to how to narrow that down. And I think the point you made about AI, I think that's where we're going to be going, where you can hopefully input your information and then get a list of studies that would be applicable to your case and then what centers they're at. And then you asked another really great question earlier as well about why do I have to go to New York to get a study? Why can't I get it, my treatment in LA? And so all of the regulations around doing clinical trials, all those strict criteria that we have to follow as investigators, we can only do at our centers. But through these national cooperative groups, if patients get randomized to a clinical trial where they're offering standard of care as one of the arms, we're now looking to see that patients may be able to participate and get treatment closer to home. So hopefully that will be coming in the future as well. And then your last question was about immunotherapy after progression on immunotherapy, for which that question is being asked right now on a clinical study that is looking at nivolumab beyond progressive beyond progression from the frontline setting, and it's being combined with the standard of care drugs for second line, ramucirumab and Taxol. And so we do have that clinical trial available. In terms of access from companies, I think it's individual. It depends on the company. And I want to also, we've been talking about the art of medicine, but we also are, we're, as medical oncologists, generally, we're evidence-based. We don't want to do things that may offer toxicity but don't have data behind them. We're really careful about doing things for which there's not support, not medical support to do it, even though it feels like we should be doing that. So I think that's another reason to kind of seek out those studies. So I guess what I'm trying to say is there's no data to support giving nivolumab after you've progressed on nivolumab, but there is a study that's asking that question.
Oh, I guess the specific question was when you mentioned if you progress on nivolumab, you won't get insurance coverage for zolbetuximab?
Because it's only approved for the frontline setting. Okay. Yeah. And so because of the lack, so I don't know of support for Zolbe in the second line setting if they don't have that indication. But maybe some of the industry partners can help with that question, at lunch or something.
So, Emmy, oh, go ahead.
Sorry, no, but as Dr. Iqbal pointed out, for patients who are looking to participate in Zolbe, that they have progressed, there are Claudin bispecific antibody trials that are available for second line, third line setting. So the access to some of these targets as well as the monoclonal antibodies comes through clinical trials. And I think your question about when and how you would identify them is a big issue for patients, and we are collectively trying to solve that also as physicians, making sure the knowledge is transferred, that we are collaborating with our partners locally as well as nationally, and putting that information out so that it is also available to patients. Even coming to these patient advocacy groups is to ensure that our patients are as informed, and the word kind of keeps its word of mouth that transfers. So all very relevant questions.
So Emmy and Crystal, I think you guys bring up your struggles and challenges and the positive and perhaps not always positive experiences as caregivers looking for or hoping for collaboration and networking amongst us, physicians and surgeons. So I think Aki probably put this topic here on purpose, because you have a captive audience. I mean, we're like locked in chairs right here with all of us who treat gastric cancer and care about gastric cancer patients in the Southern California area. And so you'd be happy to hear that we did have our first meeting this morning after decades of talking about it and maybe seeing each other like in different countries and in San Francisco at meetings. So we did have our first meeting. So I invite any of you, specifically like topics like this, where you have experience that may have, that you experience like the struggles and challenges and the solutions that you have come up with, and how such a collaboration amongst us up here on this platform can actually, like, just getting together isn't really meaningful unless it reaches you. So how can we reach you? How can this collaboration help you? And if you want to get involved, please tell Aki and let us know, because first we need a name. So it's like, I don't know, like US, West Coast, Pacific Coast, Cancer Consortium. So something as like really insightful as Stopgap. We want something like that. So think about a name, and we're taking nominations. Okay, we have selected like looking at staging laparoscopy, and I took notes. Biomarker, what is it? Second opinion as the top, and then we're also going to try to use these metrics to help improve some of the quality control that happens. And all of us were in a meeting this morning. That's why we didn't see you at breakfast. And we want your input. So all of this came from meetings for patient advocates. So if you want to get involved and help us improve ourselves in this care for gastric cancer in the United States, please join us and help us. And actually keep us honest so that we keep this going and not just end today.
Just to add something, because a patient sometimes has a little bit misconception about clinical trial. So I remember when I first took my job, my chief told me, if you put some patients on your clinical trial, you need to think about whether you are going to put your parents on the study. So with that being said, so sometimes as a provider, we know some centers have study, but you are not sure about efficacy, the safety, how can you refer your patient to them, right? So, and the second, so NCI, so like patients coming from NCI center, they have a very good medical oncologist. We don't want to step on the toes. We give advice, we give suggestions. I send patients to Dr. Wainberg all the time. I email him, say, please hurry up, the patient cannot wait. He said, I'm rushing. So yeah, we are talking to each other. It's just like, also we need some time to figure out how to help patients.
Just from the surgeon side, I'd also like to let the audience know that all the surgeons on stage we've talked a lot about each other's patients. We've referred patients to one another. And I think that it is a unique grouping in the sense that Southern California, where you guys live, has a very collaborative group of gastric cancer physicians. So I think we're really lucky to have that. Yep, you're up.
Well, I did talk to Dr. Wu yesterday and about the collaboration of doctors. Our only child in 2015 was diagnosed with adenocarcinoma. In 20 months, she was gone. As a matter of fact, she was with Dr. Wainberg's clinical trial for KEYNOTES, I believe. And, we were hopeful after the third infusion, she broke out these rashes. And I don't know if you remember that, from head to toe, that lasted for 7 months. So she was kicked out. But through all of these collaborations, what happened was we went through 4 here in Southern California. My sister works at Memorial Sloan Kettering with Dr. Jinjigian at TPS. So what it is my husband being the dutiful father that he was, he wanted to do everything for our daughter, even flying her to South Korea. Well, I said that was not going to happen. So the best part was Dr. Jinjigian got in contact with City of Hope, who at that point was with Dr. Lucy Leong, and they talked and they collaborated that this 26-and-a-half-year-old girl did not have to fly to New York. She needed her peers. She needed her support. She's a young person going to undergo this chemotherapy. You need to take care of her mental health. And that, I believe, is very paramount, especially to a young person. And so with Dr. Leong, he collaborated with our local oncologist, Dr. Thomas Lowe, at Torrance Memorial, who is affiliated with Cedars. And from that time on, when her chemo stopped, she was in contact with, Dr. Leong was in contact with Dr. Jinjigian, who in turn went to Dr. Wainberg. And when that didn't happen, we went to Angela's Clinic, which is the research arm of Cedars-Sinai, and that's where we met Dr. Sam Klempner. And so, that is an option, and I believe this collaboration, this was 2015, and I wish it would just further continue, because that time there was no ChatGPT. It was about, you Google stomach cancer and you see another organization. Aki was very fortunate to have been working at that organization during that time, and she contacted me as part of the support group, and that's how we got into all of these, and Memorial Sloan continuing to have recommendations, which City of Hope was just very more than happy to accept and continue the collaboration. And I think I'm a nurse, I'm a critical care nurse background and endoscopy as well. So I think the whole overall care team of a patient, which includes the medical oncologist, surgical oncologist, you have to have in there a nutritionist, you have to have palliative team. My daughter was in contact with the palliative team the moment Dr. Leong told her that she had stage 4 stomach cancer. And it was such a tremendous help, especially, I mean, we are in the medical field, but other lay people do not know what A is B and how to undergo that. So a social worker is very helpful. She was in contact with psychotherapists even until her last breath. They went to the hospital and then, you know, they supported her. So I think it's very important. The nutritionist, when she couldn't eat, you know, they were in touch with. That's why the Benecalorie, when the nutritionist was telling that, I mean, I've been giving that as presents to patients who cannot, because I think Benecalorie helped her gain a little bit more weight. And then the TPN, which I did 12 hours at home until it didn't happen. So I think the doctors, medical oncologists, should also be suggesting that the moment there is a diagnosis, because it is a supportive team that, you know, it helps them. You know, you don't have patients calling the medical oncologist, how do I go about this, how do I go about, but if you have a palliative team, that is your first line to contact. And another thing for those who are young patients, our daughter was given the chance to have her egg harvested. So we had to inquire from Memorial Sloan the best recommendation, and there are only two in California. One was UC San Francisco, and the other one was USC in Wilshire Boulevard. To this day, she has 21 eggs stored, and we continue doing that, and we've told the research centers that we went to for help that it's there if they need it, and for any infertile couples. So that's just what I would like to inform as
story.
palliative
Thank
team.
It's always amazing what you learn from a discussion like this, because I think when we think of the healthcare team, we think of oncologists, surgeons, radiation, you know, et cetera, but you forget about the social worker, the dietitians, and all the people that make a fertility specialist, because we are seeing a new wave of young patients. I have a number of the 20-year-old women who are, you know, these are the considerations for them. It's not just the chemo, it's fertility and how to ensure it long term. Thank you, that was a great point, really appreciate that. Any other questions, thoughts? Of course.
I had a question regarding
I get scared when you ask questions, I just want you to know right now.
Yeah, regarding the clinical trials, it seems like there's the stigma that the clinical trials are like a last option, right? You as clinicians, when you are approaching a patient and pitching a clinical trial to them, how do you put their mind at ease that the clinical trial might be a better option to them than say, just going the standard of care?
So I was actually on a clinical trial, and I'm very, very sensitive to the fact that I was on the curative route when offered this clinical trial. But what this clinical trial helped me realize is it may have not worked in my stage. We may have not seen the outcomes that we wanted in my stage, but we saw the outcomes to where it transitioned to now a first-line therapy for stage 4 patients, and just hearing 4 or 5 stories already of how immunotherapy is keeping the cancer in line kind of hones it all back into. I remember sitting in the chair and Joseph Chow offering me this clinical trial. And I remember, you know, though he was very sensitive, very sensitive in how he pitched it to me, because to your point, especially in the Hispanic community, minority communities, right, we don't want to be lab rats. And we're probably not going to get the support from our family members, because they're going to tell you, why are you going to be a lab rat? So that's very difficult in itself to overcome. But when speaking to Joseph at the time and him explaining to me, you know, I would also at this time, and like I said, I'm very mindful that not all clinical trials work this way, but I was also going to get the standard of care treatment no matter what at the time. To me, in my heart, it almost felt like a no-brainer. But then, and I use this, and I think I've spoken to some of you this weekend about it, like when I was on the clinical trial, and I did have a lot of obstacles to overcome. Family members didn't agree with it, but luckily I had a really strong support system from my wife at the time, who was in my corner. But when I was on this clinical trial, and I say this lightly, but I really do mean it. Like, I felt like I was a rock star. I truly did, and for a couple reasons, right? Number one, obviously, I was hoping that it was going to have good results, not only for myself, but for the future. But also, I had my own clinical trial nurse. I had multiple follow-ups. When I was doing my treatment, I had almost like a little room. I just felt like I had so much more attention to detail that they were focusing on with me, that I knew my team cared. And I know Aki asked this question in the last session, like how I feel about my team. Like, I love my team. My team is like my second family. There was a point where, because of the clinical trial, I was going to City of Hope, it felt like every other week, whether it was for treatment, blood work, scans, immunotherapy. I mean, it felt like I was there more than I was anywhere else besides my house. But it really, really put that at ease for me. And, I'm very, very thankful for it. But to your point, though, it is tough and it is hard to overcome. You just kind of got to listen to your team, and I'm sure they'll chime in more. And then also, I just try to remember that, and I always use this, I try to just do the greater good. If it didn't work for me, I just hope maybe it worked for somebody else and kind of gave us more answers.
So for our panel, what thoughts do you have when you go to talk to consent a patient for a clinical trial?
So one thing, Frank always asking the provocative questions. So the concept of a clinical trial being only for patients who have nothing else left, I think that's something that we should get the word out and correct, because of your participation in that study, now immunotherapy is approved for perioperative care in patients with gastric cancer and has improved outcomes now for patients going forward. So, and that was a curable setting where we had standard of care options. So I think that's something that's important for us to realize, that it's at every line of therapy. Every time your doctor talks to you about changing treatment or starting a new treatment, that should be the time to think about, is there a study potentially that I might be interested in that could offer me maybe something different or something more. But I actually wanted to ask, what was it that made you kind of overcome all these barriers that you identified to saying yes to a study? I mean, the greater good is fantastic, but do you think that's going to reach most people?
So I've always been kind of like my own trailblazer, and I've always walked the line of trying to live a little on the edge, I could say, but when it came down to this diagnosis and when I got sat down, it's kind of like everything comes into perspective. Your life just, it's like the movies, like you're almost looking at yourself from above, right? You're seeing, like, you're having an out-of-body experience. So when they presented this clinical trial with me, something in my heart just was telling me, like, to do it, like, go for it. I was very in tune with what was out there already, just because I had done my research, and Dr. Wu could speak to it. I used to send her articles about trials and just yeah, from Spain. I mean, you name it. But I think it was definitely in my heart. But the heart, and I mentioned the hardest thing was overcoming family. Like, that was the toughest part, because believe it or not, my families were more of the detractors to it. And how do you explain to your first generation, you're explaining to your immigrant parents, like, who only know clinical trials as lab rats, I know it's gonna be okay. Like, how do you overcome that? And those were a lot of difficult conversations that I had to have. A lot of self-reflection when I did make this, because I'll be honest with you, when I did make this decision, even in my head, I thought, was I making the right decision at the time, right? I mean, I think it's just natural. But a lot of self-reflection, a lot of thinking of others, a lot of being thankful that I had the opportunity to possibly beat this. All those things came in, And I weighed out the benefits, and I decided just to take that leap of faith and go for it. And I'm very thankful that I did.
Actually, that's kind of the point that I was asking about, is that, you know, he had to explain to his family and kind of convince them that a clinical trial is a good way to go. I'm just thinking that what can be done to, that it doesn't have to be that way, because, you know, you don't have to explain to your family that you know, if you're going to do standard of care, for instance, right? You don't have to sell it to them. So I guess what I'm asking is, like, how do we get to the point that, you know, if you're offered a clinical trial, that you don't have to be so concerned to have to explain it to everybody about it, you know, to sell it to them?
I think this actually brings up a really, really good point for for Frank and personally experiences of barriers of you know, having choices to make outside of standard of care and clinical trials or not. And to your point, Frank, I think it's about education and awareness about what clinical trials are and how they may be a little bit different today than they were in 1996. So in 1996, when I was thinking whether or not I was going to go to med school, I was working at at MGH doing like clinical trial coordination. And at the time, I was informed that only 2% of all drugs that were being tested will ever be effective, okay, after like millions and millions of dollars. But now I think the statistics are different, but the perceptions about being, feeling like you're just being a lab rat, this actually in the ethnic communities is pretty real and very often encountered if you meet with community leaders, especially with NCAACP, the Hispanic community. But one thing to remember is we need to do the education, but there is a very low participation amongst ethnic minorities, right, in clinical trials. But these clinical trial results affect how we treat all of America, right? Whether or not there was one Hispanic patient, one Asian patient, and 99 white patients, right? If we try to do gender and male and female, we even do that in, you know, preclinical animal models. We want to be broad and diverse. So ultimately, for all of cancer care, not just for gastric cancer, it is extremely important that there's ethnic diversity in the trials, and the global trials obviously will go to that and make sure that we have the diversity, heterogeneity, et cetera. The other point I wanted to make is it's different whether you're going on to a phase 3 trial, randomized controlled trial, where you have the standard of care plus or minus something else, versus a phase 2 trial. Well, you know, usually you get the plus, and the phase 1 trial, we're trying to dose escalate to find the right dose, the effective dose, and evaluate the toxicities. So I know you guys are out there, this group is extremely well-versed, but out in the community, when people are looking for clinical trials, they don't know the difference, or some of us don't know the difference between phase 1 and 3, and I think it needs to be explained very, very well. Like, what is the goal of that trial? And what is the drug that you're getting, and what is the expected outcome either way? Is it testing for toxicity? Is it testing for is some group better than the other group? And that may change your mind. And the last point is, in gastric cancer, unfortunately, when you pass first line, you fail first line, the second line isn't that great. And then third line is even worse. So during first line, we may want to explore possible new drugs, targeted therapies that have so much potential, in addition to standard of care or something else, so that we are informed about the choices. What happens if I fail first line, right? The statistics say 5-7 months in second line. How do we beat that statistic? Well, maybe there's a new drug, like Pembro was for many people, like Herceptin was for many people. So I would consider these things and ask these questions of your physicians and surgeons.
That was an excellent summary to that panel. Thank you very much, Dr. Wu. So a lot was learned, and I want to thank especially our patients for volunteering their stories and opinions and thoughts. Thank you guys very much.
I think that we should take a photo.
Oh,
Can we get an entire session photo? This is the last photo, right?
Aki's got a couple of words to
you
share
have
with
the
us.
last- yes.
Yep, got the last. Come on up.
Hi, sorry, this is my son Kai. I missed a lot of his games this weekend. So. Hello. Hi. Okay, so I just want to say thank you to all the doctors. I couldn't sleep last night. I was wondering how this panel was going to go, but it went really brilliantly. Thank you so much. We are so honored that you were able to join us. This has been an incredible program, and we want to thank you all for being here. We have nutrition guides that we can distribute to you guys, and you guys can take a case to share with your patients. I also want to thank our generous sponsors, who without them, this program wouldn't be possible. This upcoming March, we will have our 5th Patient Empowerment Summit and Advocacy Day. And before we break for lunch next door and pictures, we have a quick recap video of the weekend. Thank you all again for being here, and we look forward to seeing you in March. Thank you. It's just a minute. It's just a minute. Done with the live streaming. Thank you again so much.
Can we try to get a photo? Aki, don't go away.